Good morning, everyone.
Morning.
Thanks all for coming to this enhancing motivation and adherence in health context. I'm really pleased with the amount of people that have come to this conference. Certainly the academics are coming up to their sort of midterms, and the non-academics are always busy anyway. Not that academics are not busy. But yeah, thanks. And also, I'm really chuffed with the quality of the person. We've got some really good academics. We've got some really good people who work with. I was talking to somebody about this morning about how much they work with older adults and getting them active and various important roles outside of academia. So I'm very happy. Just as a bit of admin, the fire exit is out this door because it's the only door in. So if there's a fire there, we'll be sitting. But the fire exit is that way, back out where you came, and we meet there. Okay, outside there with the squirrels. Toilets are hooked back in where you came, so through the coffee area and round near the lecture theatre there. And we'll have coffee there at 11:30 today. We're going to talk about health context today, and that can be a variety of things. We've got some talks on physical activity. We've got some talks on medication adherence. I'm a big believer in there are generalisable principles of motivation. So whether you're trying to motivate for physical activity, whether you're trying to motivate for medication adherence, a healthy diet, I think there's take-home messages and generalisable principles, whatever the talk. So even if if we're looking at a talk about physical activity and that's not your area, I think there's some good take-home messages that you can do. And so what we're going to do, I'm going to ramble on for 5 or 10 minutes about the welcome and introduction, and then we've got Dr. Sally Fenton from the University of Birmingham talking about sort of using a certain specific theories and how that translates to practice, and that follows nicely into Dr. Fiona Gillison from Bath, who will talk about how that has worked in her experiences of translating theory to practice. Then we'll have a quick refresh. And then we've got Professor Mark Connor from Leeds talking about real conscious intentions to be active and how that can transfer to behaviour. Bit of lunch, and then we've got a nice little different talk in that most are about conscious motivational processes. Professor Madelynne Arden from Sheffield Hallam will be talking more about habits and making behaviours automatic in the context of medication adherence. And then, last but not least, we've got to Dr. Fuschia Sirois from the University of Sheffield, who will talk about self-compassion and how that can be used to motivate behaviour. And then, sprinkled, there's a couple of discussion sections. The first one, if we get time, will be just to sort of talk about the first 3 sessions, and then Dr. Anthony Popper-Thomas from here will be hosting a discussion session about the last 2 talks. And what I really want there is for that to be non-academic led. As I said, all the talks are from 5 academics, and just really thinking, okay, what can I take home? Or that doesn't fit with my experiences of working with older people, younger people, and so forth. So hopefully those discussions will be really practitioner led. And then I shall wrap up at about 3:30 with just some concluding remarks and thoughts. One thing, a few thoughts that I think and what should guide the day. Behaviour change is much cooler than motivation. Okay, you see behaviour change everywhere, and I actually think behaviour change is missing a bit of a trick by focusing too much on behaviour. I think it's quite easy to, or not easy, but relatively straightforward to trigger behaviour. But that doesn't necessarily happen in very healthy ways or very sustainable ways. So motivation is the fuel behind the behaviour. And like any car, you can put good fuel in or you can put awful fuel in. And it still might get you to B, but it won't do your insides very well. It won't be a very healthy process. Okay. So I think that's an important point to make. I think as well, when we're talking about health context, we're talking about 2 different things. Getting people to be initiating physical activity, taking medication, a healthy diet, but also sustaining that healthy lifestyle in the long term. And sometimes, not always, but I think they're very, very different motivational processes. I think incentives are a good example of that. Incentives are a fantastic initiator of behaviour. Okay? I could probably get somebody to do 20 press-ups here now for £20. Okay? But to do that in the long term, I would need much more than incentives. And I think that's, yeah, so I think bear that in mind throughout the day, that the initiation is very different to maintenance in some instances. And then related to those points as well, I think motivation is particularly good at helping us understand the interplay between psychological and physical health. Like what I said before, behaviour change is not really very psychologically healthy. I can think of a lot of people who exercise for not very good reasons. Okay? And so on the outside, their body is super, super fit, but do they do that in necessarily psychologically healthy reasons? I'm not so sure. So there's that interplay between can we use motivation to understand to get people physically and psychologically healthy at the same time? I think we can. That's enough of me. We'll get into the meat of the day now. And I've lost Sally. Where's Sally? First up then is Sally Fenton from the University of Birmingham, talking about the translation of theory to practice.
Morning everybody. Sorry if my voice goes a little bit, I'm suffering with a bit of a cold, so I might get a bit croaky throughout. Thanks Ian for inviting me to talk today. The focus of this talk is going to be outlining the current landscape in terms of what we currently know regarding physical activity interventions in clinical populations, and then I'm going to draw on one particular theory called self-determination theory, which I'm sure some of you are familiar with in this room, to highlight how we've used self-determination theory to inform an intervention that we've delivered in a clinical population, and then hopefully from that you'll be able to take some ideas and key principles that you might then be able to apply if you're in research, policy or practice. So first of all, I'd like to put the problem into context in terms of physical inactivity in patient groups. So we know that national guidelines say that people should be engaging in 150 minutes of moderate to vigorous physical activity per week, and this was upheld in the recent guidelines that were just revised and released at the start of September. And we know that this level of activity is associated with reduced risk of developing different non-communicable diseases such as heart disease and type 2 diabetes. But what we also know is that engaging in moderate to vigorous activity, if you have a chronic disease, can also help to improve your health outcomes, and it can reduce the burden of disease for you as well. And it's recommended as a non-pharmacological management technique in different populations with chronic diseases, including people with musculoskeletal disease, as well as heart disease and type 2 diabetes, for example. And despite the fact that we know that physical activity is beneficial for these patient groups, what we consistently see is that they're not engaging in the levels of activity that they need to accrue some of these health benefits. And some really strong data for this comes from a recent cross-sectional analysis of the UK Biobank data, which was published this year. And what they did with this analysis was they took data from around 97,000 participants who were aged over 40, and they had worn a wrist-worn accelerometer to measure their physical activity. And in the analysis, what they showed is that when they looked at those people who were diagnosed with a chronic disease, they were consistently engaging in lower levels of total physical activity on a day-to-day basis. This analysis also looked at levels of moderate to vigorous physical activity engagement. And what they saw again was that of all of the chronic conditions that were observed, there were 67 in which levels of moderate to vigorous physical activity were consistently lower than those healthy controls or healthy people in the population who didn't have chronic disease. And the lowest levels were seen in terms of people who had mental health disorders, cardiovascular disease and neurological disorders. So there's quite a degree of variability, but it was consistently seen that people who have these chronic diseases are engaging in total lower levels of activity overall, but also that moderate to vigorous health enhancing activity that's recommended. So what we really need then is interventions that can support these people to engage in more physical activity, and also to engage in that moderate activity that gets them a bit sweaty and out of breath, so that they can accrue some of these health benefits. And now that might seem very obvious to say, we know that these people don't engage in that much physical activity, but what we tend to see is that there is a relative lack of interventions that are directed at specific patient groups. There's quite a few interventions that are directed at people who suffer from cancer, so cancer survivors, or heart disease or type 2 diabetes. And that's because these people comprise big portions of the population. But there are some patient groups of people who've got, for example, people with neurological disorders, autoimmune diseases, and they are given relatively less attention. And what we need to do is try and have a more broad outlook in how we can look at the factors that influence people's behaviour across all of these different patient groups and understand the different patient groups to support them more equally to be more physically active. And the reason that I think we see more of these interventions in these bigger patient groups as well is that they're easier to access. It's easier to go and recruit patients through primary care, for example, than it is to establish a really good collaboration with an NHS trust or a consultant who's research active and is interested in physical activity. And so I think that that's where we need to really, as researchers and as people who are working in healthcare, work together to try and establish those collaborations so that we can really reach these hard to reach populations. So what I wanted to do was to now highlight some of the evidence which is already out there in terms of the interventions that are being delivered in some of these patient groups. And a way that we can do that is to look at meta-analyses of interventions that are quite homogeneous in terms of the population they've targeted and the ways they've measured physical activity and the approaches that they've taken. But again, because most of the research is done in these populations that comprise most of the general population in terms of chronic disease, most of the meta-analyses are focused on these three chronic diseases here, so cardiovascular disease, cancer and type 2 diabetes. And one of these meta-analyses that I wanted to highlight was, again, recently published this year, and they looked at 138 interventions which included around 13,000 people. And on average, this is kind of a snapshot of the figure taken from this paper, so it's not the whole figure, but it gets the point across that I wanted to make, which is this blue line here is the standardised mean difference. So if an intervention had no effect, you would see that this black box is sitting on this blue line. This red dashed line here is the average estimated effect of the intervention. So in essence, what this review showed was that there was a significant increase in levels of physical activity overall in general when we looked at these 138 interventions. However, this effect was quite small. So the effect size was around 0.3 and it equates to around 1,500 steps per day, which isn't a great amount, and anybody who might have a wearable device themselves or report their physical activity knows that 1,000 steps per day can be quite negligible, especially if it's measured on a wrist or an accelerometer, for example, and you're driving a car. You're accruing 200 steps per day just sitting in a car. So there's promise, but it's not where we would like it to be. The other point is that these interventions are highly variable in terms of how effective they are. You've got some interventions which are having a far greater effect than 1,500 steps per day, and some which aren't being successful in changing behaviour at all. And when we look at a meta-analysis that's just been done in type 2 diabetes as well, you can see a similar pattern. So there's a high degree of variability. This meta-analysis again showed that there was a significant increase in levels of physical activity in response to the intervention, but again it was small, and we can see that it's just not consistent in terms of how effective these interventions are. And if it was me that was receiving one of these interventions, I don't know about you, but I'd be wanting to be assigned to one of these rather than one of these down here. And what we really need to start to do then is understand why those interventions are more effective. What is it that these interventions did that these ones didn't do that meant that these patients engaged with them and changed their behaviour to a greater extent? And one way that we can do that is by developing theory-based interventions. And what theory allows us to do is it gives us a framework that we can use to guide our intervention development, but also to evaluate our interventions and understand how things worked. And they can tell us, if we use theory as a framework to evaluate the intervention, we can start to pick out what are the active ingredients of the intervention, what has worked, what hasn't worked, and then we can take the components of interventions that are most effective and enhance them, and then redundant components which don't seem to be working on the basis of theory we can eliminate. And then through an iterative process of kind of developing, testing, refining, developing, testing, refining, we can start to develop interventions which hopefully will have a greater potential to promote physical activity towards this kind of degree. So just to give kind of a brief overview of psychological theory then, and how we would use it in intervention to be a bit more explicit about it. When we refer to psychological theory, we're talking about a framework which specifies a series of interrelated psychological factors which we assume to work together to influence a specific outcome. So in this case, we're talking about physical activity. And so what this framework does is it provides us with options, essentially, for intervention, development and evaluation. And it can tell us what we need to target. So what are the psychological factors that we assume or have been evidenced to be linked to physical activity that we can target with an intervention that exist within a psychological framework. It also helps us to identify how to target them. So it can also allude to psychological factors which can target those determinants which are so closely linked to physical activity so that we can change behaviour. And then it provides, as I just mentioned, this framework for evaluation where we can start to see how the intervention may or may not have worked. So this diagram here is kind of to give you an idea of what you might expect to see if you were going to see a theory kind of outlined in a research paper. And if we were to have an intervention that was based on psychological theory, that intervention would have identified then some psychological constructs which we refer to as determinants of behaviour that the literature has shown are consistently linked to our targeted outcomes, so in this case physical activity. And that might be empirical evidence from experimental studies, it might be observational evidence, it might be research that has just tested the theory in the physical activity context. But what we need to do is make sure that the theory we select and the constructs that are specified within that theory have evidence for their associations with physical activity. Otherwise, that theory is probably completely redundant if you're going to apply it to a physical activity context, or it needs to be tested in order to get to the point where you can have some confidence that it would be relevant. So a theory specifies these psychological constructs, and in doing that, what it does is it allows us, as I've said, to understand how the intervention's had an effect. So if our intervention can target these determinants or psychological constructs which are linked to physical activity, then what we would expect to see with the intervention is that these determinants will change in response to whatever intervention we implement. So we might have an intervention, for example, this determinant could be self-efficacy, if it's self-efficacy theory. So we might have an intervention which involves modelling, which in self-efficacy theory is hypothesised to be a strategy which would positively impact self-efficacy. And so if we had an intervention which delivered modelling as a technique, what we could do is measure self-efficacy before the intervention and after the intervention, as well as physical activity, and hopefully what we would see, based on the fact that we have grounded our intervention in this theory, is that self-efficacy has changed from pre-intervention to post-intervention, and that we've also seen a change in physical activity. And hopefully that gives you an idea, I guess more practically, about how you might use theory to inform an intervention in terms of specifying these determinants that are linked to physical activity behaviour. So given that the topic today is on motivation, I wanted to talk about some motivation-based theories that have been used to guide intervention development. And motivation-based theories have received quite a lot of attention in the area of physical activity on the basis of the fact that there is consistent evidence that motivation, in whatever form it seems to be operationalised within different theories, is consistently linked to levels of physical activity. So that there's evidence there for that determinant. Motivation is one of those determinants that we know influences levels of physical activity engagement. And the reason why this is such a good determinant to target as well is the fact it's modifiable. We can change it. It's not stable. And there are quite a few reviews of the literature which have looked at determinants of physical activity, and what they tend to highlight actually is that we know a lot about who to target interventions towards, and we know a lot about determinants in terms of demographics, so age and gender, for example. But we don't know how to change their behaviour, and we don't know what these modifiable determinants of behaviour are. So motivation gives us one of those modifiable determinants that we can target through intervention, and we know it's consistently linked to physical activity. In terms of its relevance to clinical populations, there's also evidence to suggest that this factor influences levels of physical activity over and above some of the symptoms or outcomes that patients report as being debilitating barriers to engaging in physical activity. And I'm going to highlight some evidence that we have from a particular population later to make that point. So when we think about motivation-based theories, it's suggested that they can be classified into 5 kind of different domains. So belief attitude theories, competence-based theories, control-based theories, stage-based theories, and hybrid models. And in the context of physical activity, self-efficacy theory has been a theory which has been quite widely investigated, but also self-determination theories is receiving quite a lot of attention in the physical activity domain. And again, a reason for that is that this theory has been tested quite extensively in the physical activity context, and there's consistent evidence that the theoretical tenets of SDT, self-determination theory, and the psychological constructs that are specified within that theory are significantly associated with variability in levels of physical activity engagement. So there's that empirical evidence base surrounding this theory, which means that it's useful to pull from when we're developing these physical activity interventions. So just for people in the room who aren't familiar with the theory, I thought I'd give a brief overview to provide some context around the intervention that I'm going to talk about. A central tenet of self-determination theory is that we have a quality of motivation, which is different to quantity. It's not how motivated we are to do something. It's, as Ian alluded to in his introduction, it's the reasons why we are engaging in the behaviour, and that is highly variable. It can range from reasons that are quite external, for example, incentives or monetary gain, to feelings such as fun and enjoyment, and because we really identify with benefits of it. And self-determination theory then suggests that this quality of motivation can sit on a continuum which ranges from high to low. And that variability in quality of motivation has different implications for cognitive, affective and behavioural outcomes, so for example, physical activity. And in terms of different types of motivation that you might see that sit on this continuum, at the top of the continuum we've got intrinsic motivation, which is kind of the quintessential type of motivation. It's engaging in a behaviour because it's fun or it's enjoyable. So people who engage in physical activity who are intrinsically motivated might be going for a run because they can't get enough of it. They absolutely love being out there pounding the pavements, which wouldn't be me. The lower down the continuum, which is still a relatively high quality of motivation, is something that we refer to as identified regulation. And when a person is guided by identified regulation, they're engaging in a behaviour because they personally identify with the importance of that behaviour. They perceive it to be of benefit to them. So for a patient, for example, they might engage in physical activity because they have experienced the benefits of physical activity in terms of how it's improved their health, and then they are identifying with that as being beneficial, and that's why they're engaging in physical activity. So we might see quite a lot of that in patient groups. Lower down the continuum, as we get into the more controlled types of motivation, we've got introjected regulation. And if someone's engaging in behaviour through this regulation, they're doing it because they're trying to avoid internalised contingencies such as feelings of shame or guilt. So a patient who exercises due to introjected regulation might be doing so because they have been told by their doctor that it's a good idea, and so they feel like they should do it and they really don't want to, but they still go and do it anyway. And then at the bottom of the continuum we've got external regulation, and this is engaging in a behaviour because of external pressures. So you're going and doing exercise at the gym or doing physical activity because someone's told you to and someone's forcing you to do it. So it might be someone who's had a heart attack and their other half is saying to them, if you don't go to the gym and do some exercise, then I'm going to have some issues, and they're doing it because they're being forced into doing it. And then we've also got a motivation, which I'm sure you have all heard of, which is just a complete absence or lack of motivation at all. And when self-determination theory is used in the literature, often what we see is that these two more high-quality motivations are grouped together to represent autonomous motivation, and that's what I'll refer to for the rest of the presentation. And then these two motivation regulations lower down the continuum are referred to controlled motivation. And it's the autonomous motivation that we can see has more positive cognitive, affective and behavioural outcomes. And the evidence around self-determination theory suggests that where individuals are more autonomously motivated, they consistently engage in higher levels of physical activity. And that's not just in terms of adoption of physical activity, but people who are autonomously motivated engage in physical activity for longer periods of time. They sustain that behaviour and it's maintained. So for patient populations who we want to really support in changing their behaviour over a long period of time to help self-manage their disease, autonomous motivation is something which could be used as a really valuable vehicle to help do that. Looking then at autonomous motivation specifically in the healthcare context, I wanted to highlight this meta-analysis which was done a few years ago, which compiled data from 184 studies that use self-determination theory in this environment. And what they showed was that more autonomous motivation, so intrinsic motivation and identified regulation, again were consistently linked to these high levels of exercise and physical activity. What I also wanted to highlight was that this meta-analysis also showed that autonomous motivation had a significant positive effect on psychological well-being, and that was regardless of levels of physical activity. So feeling autonomously motivated towards health behaviour in a clinical context can also just help people feel better. It can help reduce levels of depression and anxiety and improve perceptions of quality of life. So autonomous motivation is not only useful to promote physical activity in these groups of people, but it also might help to just generally make them feel better day to day. And going back to the point I made about how autonomous motivation might be of benefit in terms of affecting behaviour regardless of disease symptoms to a certain extent. This is data that we have from a recent cross-sectional study that we've just finished in patients with rheumatoid arthritis, which is chronic autoimmune disease. And we assessed autonomous motivation with questionnaires and physical activity with hip-worn accelerometers. And we also looked at self-reported pain and a measure of disease activity, which is the clinical marker used by consultants in day-to-day practice to indicate whether patients are experiencing what we call active disease flares, where their inflammation is kind of through the roof and they've got joint pain and swelling and they're not able to really move around a lot. And what we found in this analysis is that autonomous motivation significantly predicted physical activity, even after we controlled for the variability in feelings of pain and disease activity in these patients. So that's not saying that these factors don't affect physical activity, because they do. We saw significant associations with both of those factors in levels of physical activity. But what we saw was that autonomous motivation had a positive effect on levels of physical activity, even when we took those things into account. So I think that that's quite powerful when you think about the fact that things such as pain and fatigue tend to be very common barriers that patients report when they're talking about why they don't engage in physical activity and exercise. And so by targeting autonomous motivation, what that does is perhaps give us a potential avenue that we can explore to help them engage in behaviour change, not just in the short term, but in the long term, and it also might help to override some of these more debilitating barriers they're reporting. So going on then to look at how we would target autonomous motivation, what would we do to try and enhance autonomous motivation in these patient groups to try and promote physical activity? How can we deliver an intervention which does that in the healthcare context? Typically, self-determination theory-based interventions focus on the content and style of communication between social agents and significant others within a particular environment. So in this case, it would focus on the interpersonal behaviours of a significant person within the healthcare context, so a GP, for example, or a consultant, or an exercise trainer. And the interventions work with those people to get them to try and create a social environment which supports a sense of autonomy and fosters that autonomous motivation in their interactions with patients. And to give kind of a very superficial idea of what these interventions might look like, and very simply, what they try and do is get these significant people to give the person they're trying to change their behaviour a choice and a voice in regards to their physical activity engagement. So we call this creating an autonomy supportive environment. And the way that this can be done through three kind of very overarching techniques is to just promote choice in how these patients might go about engaging in physical activity. So not being very prescriptive, but talking to them about how they want to be physically active and giving them different options about how they might go about it. Providing meaningful information and a rationale for the behaviour that you're targeting, so explain to them why physical activity might be of benefit. For example, in our patients with rheumatoid arthritis, it might help to control their disease activity, it might help to reduce their fatigue, it might mean that they're more mobile day to day. And if you can get patients to resonate with those things, that can foster that more autonomous motivation and help them to engage in behaviour change. And then also, what is important to do in this is acknowledging an individual's perspective and seeking their input. So again, it's not being prescriptive, it's listening to the patient, understanding where they're coming from in terms of their levels of physical activity or their previous engagement in physical activity, and asking them and speaking to them about how they might change their behaviour and how they might want to go about it. So going back then to this concept of what theory enables us to do when we're developing an intervention and evaluating an intervention, you can see that self-determination theory gives us the psychological factor to target, so the determinant. It gives us the strategy that we can target that determinant with, so it tells us how we can influence behaviour. And it also gives us this idea of looking at how the intervention works. It tells us, helps us to try and identify what the active ingredient is. In this case, we're hypothesising our active ingredient is autonomous motivation. So it ticks all of those boxes in terms of what theory should help to do when we're looking at enhancing interventions. So I just wanted to go over an intervention that we delivered, again, in patients with rheumatoid arthritis, to highlight how we use self-determination theory to develop these autonomy supportive social environments that promote autonomous motivation, and then show you how we evaluated whether that intervention worked in terms of looking at that active ingredient. So briefly, rheumatoid arthritis, I think I alluded to this, as an inflammatory autoimmune disease which is characterised by chronic systemic inflammation. So it's not like osteoarthritis, it's autoimmune, and it causes things such as joint pain and swelling. Patients are severely fatigued, they've got compromised physical function because it manifests as joint damage, and it's comorbid with cardiovascular disease and depression. So this patient group, I think, are at 50% increased risk of developing heart disease compared to the general population because of that elevated systemic inflammation. And this intervention that we delivered was a multi-component self-determination theory-based intervention to promote autonomous motivation to engage in physical activity in these patients. And it was a 2-arm trial, so we had a control arm who didn't receive the intervention and an experimental arm who did, and we compared the effects of, we compared outcomes in those 2 arms. Both arms, and this is slightly different to what you might see in a typical study design, both arms actually received an exercise intervention. And the reason for that is that we wanted to give all participants the opportunity to engage in exercise. The difference between these 2 intervention arms was that one of them, so the intervention, received the exercise programme, but also they had one-on-one consultations with a behaviour change counsellor who was trained in self-determination theory and these principles of trying to create autonomy supportive social environments. So they had kind of the additional psychological component to the intervention. And this would set aside this intervention from other interventions that might have been included, for example, in the meta-analyses that I presented earlier, that have just simply delivered exercise or physical activity prescription to populations to see if it changes their behaviour. So this self-determination theory programme is really looking at the active ingredient of autonomous motivation and setting it aside simply from just delivering an exercise programme. In terms of how these autonomy supportive strategies were delivered, the aim was to acknowledge patients' experiences of physical activity and then provide this idea of giving them the choice and the voice over how they engaged in their physical activity behaviour, and I'll talk a bit more in detail about those techniques in a moment. This was the study design, so as I said, we had 2 groups that were randomised to either the control or the experimental arm. The intervention arm, who had the self-determination theory-based consultations, had one at baseline, and that was an hour long. And then they had 2 telephone consultations as well during their 3-month exercise programme, in which they talked to this behaviour change counsellor about their ongoing experiences of engaging in physical activity throughout. And the outcomes that were assessed were self-reported physical activity. We also did use accelerometers, but compliance was really poor, so we're only reporting the data for self-reported. We measured the self-determination theory-based construct, so we looked at the provision of autonomy support and we looked at autonomous motivation towards physical activity. We wanted to see if that changed in response to the intervention. And then we measured a range of other disease outcomes as well. In terms of what these self-determination theory-based consultations entailed, the first consultation was the most intensive, and this was really where we tried to get into it and help to support them initiate that behaviour change. During this, we tried to, as I mentioned, talk about their positive and negative experience of physical activity and get them to start to think about the benefits of physical activity for them in terms of how it might improve their disease outcomes and their own experience of rheumatoid arthritis. We also got them to encourage and reflect on the links between physical activity and personally meaningful life goals or events. So for example, I spoke on the phone to a man after this intervention. He said that all he wanted to do was be able to walk without his walking stick. And when I was on the phone, it was like, oh, it's the best thing since sliced bread. I've been out walking every day, and it really helped him to achieve that goal. So getting them to identify that from the outset is something which helps, seemed to help anecdotally at least, with that qualitative research to help them to engage in that physical activity behaviour change. We also employed some behaviour change techniques such as engaging in decisional balance, which is weighing up pros and cons of exercise and physical activity, and patient-centred goal setting. And just to go back to something that Ian talked about in his introduction, I want to be really clear that there is a difference between behaviour change techniques and theory. So often what people do with interventions is they employ behaviour change techniques and they just mention a theory and they then say their intervention is theoretically based, and that isn't the case. Behaviour change techniques are things like goal setting, self-monitoring of behaviour, giving feedback. And those things are all useful, but the way that they can be delivered in an autonomy supported manner. There's a difference between goal setting, which is prescribed and saying, okay, I want you to achieve 10,000 steps a day, and goal setting, which is led by a patient, which is supporting that feeling of autonomy. So when you are looking at the literature that highlight these behaviour change techniques and suggest that they're theoretically based and they're just target psychosocial constructs, unless they're telling you exactly how they're doing it, then just be kind of aware of the limitations of that. So the telephone consultations then that were delivered during the 3-month intervention just tried to generally support attempts to change behaviour, normalise any attempts to be physically active and help patients engage in problem solving. So if they had a barrier to their physical activity plans, we talked about how they could overcome those barriers and set some goals to help them address them. And then the face-to-face exit consultation at the end of the 3-month programme, we tried to kind of wrap up their experiences across the 3 months. So we wanted to see if patients had internalised the reasons for being physically active. Had they really identified with why it was a benefit, or were they still doing it because they felt like they should, or were they not engaging at all? To do that, we had them verbalise their fears towards physical activity so that we could really talk about what they were experiencing and try and guide them back towards this idea of having more autonomous reasons for physical activity engagement. And we helped them to plan for physical activity in the future as well. So, going back to this idea of looking at how the intervention works and why theory is important, this here is the model that we tested to see whether our active ingredient of autonomous motivation accounted for the effect of the intervention on our outcome, which was physical activity. We also, though, due to various evidence and especially this meta-analyses that showed the effects of autonomous motivation on psychological health, we wanted to see if autonomous motivation actually has an effect on psychological outcome as well in terms of patients' well-being. So we looked not only at physical activity, but we looked at the direct effect of motivation on positive psychological well-being as well. And so this is the model that we tested, and what you can see is that, sorry, I've got time on my watch and it's going off. What we can see is that the intervention, so these lines here represent associations between variables, and the bigger this number, it ranges between 0 and 1, then the stronger the effect. And what you can see here is that the intervention had a significant positive effect on autonomous motivation at 3 months. So those patients who received the intervention, their autonomous motivation significantly increased at the end of the intervention, and that translated to a significant increase in moderate to vigorous activity as well as an increase in subjective vitality, which is an indicator of positive psychological well-being. So we can say here that this active ingredient that we hypothesised was significantly impacted by the intervention. It did work. Our autonomy supported strategies did foster that autonomous motivation, and then that did translate to these positive changes in behaviour and psychological well-being as well. So what are the implications of this then for practice? What we concluded was that this study demonstrated some support for self-determination theory in the clinical context and in this particular patient group. It highlighted how autonomy supportive interactions could be used as intervention strategies to promote physical activity in these patients. And then, as I've said, it told us that autonomous motivation could represent a modified determinant of physical activity that could be targeted via intervention. And so if you think about the message that you could give to health professionals, then we could think about the importance of the discussions that people are having in the clinical setting with their patients and the manner in which they're delivering messages about physical activity. And one thing that I wanted to really highlight though was that this intervention has been done in one group of patients on the basis of evidence that we have developed in this group of patients regarding the role of autonomous motivation. But that doesn't mean that it can be applied to any patient population. What needs to happen is that we need to start developing the evidence base in different patient groups and finding out what are the determinants of behaviour for somebody with multiple sclerosis or somebody with osteoarthritis, for example. They're likely to be very, very different for different people, and there's also likely to be very different barriers for these different patient groups. And motivation might not be as salient for somebody with lupus as it is for somebody with rheumatoid arthritis. We really need to start to unpick for these very specific populations what are the factors that associate with their physical activity that we can target and do support behaviour change when we take into account everything else that these people are dealing with on a day-to-day basis. And even within a population, you're going to see some variability. People are different, we know that. And so these interventions are likely needing to be very individual specific, very person specific. It's unlikely that we can apply a global approach. And the reason this intervention may have worked is because they had a behaviour change counsellor who sat with them one-on-one for periods of time to talk about them as an individual to support them to change their behaviour. And unfortunately, the healthcare context as it stands doesn't offer that as a resource. It's not something that can be rolled out and implemented in practice day to day. And so that's something that we really need to work together to generate the evidence base for, to be able to have some assertion and go and say, if we want these people to change their behaviour and be more active and experience the health benefits and reduce the healthcare costs and achieve all the goals that the NHS want us to achieve, for example, we really need to be investing in this sort of research. And that's just talking about what I said. I'm going to skip over this because it's everything that I've said. So in terms of where to next then, as researchers, we need to be working to establish that evidence base to develop interventions, and we need to make sure that our research is informed by the psychological theories. And there isn't just self-determination theory, there are a whole host of theories out there that might be relevant. There's new theories such as the affective reflective theory, which is not a theory of motivation, but it talks about affective responses, which is probably something that's very salient for patient groups because it's something that they may have had a negative experience with physical activity because of their disease, which then might affect their motivation to engage. So there's ways that we can use theories and integrate theories, and we don't need to just be very focused on a specific theory when we're trying to explain behaviour. And then we need to test those theories to be able to understand how interventions work and then refine interventions and optimise them to make sure that they're as effective as they can be. As practitioners, what my recommendation would be to try and engage in evidence-based practice. It's quite hard with the resources that I think are available, but you can keep it simple. The message that I just gave here was give people a choice and a voice. Let them talk about their physical activity if you can, if you have time, and get them to think about how they might want to engage in it. And by applying these very simple principles, you do have a high potential for impact in the fact that you're seeing patients on a day-to-day basis. And then as policymakers, what we really need to be doing is investing in these evidence-based interventions and not just looking for short-term fixes that have shown, an increase in behaviour in 3 months but then aren't sustained over a long period of time. We need to invest in developing the evidence base that we can then use to inform these interventions that will have a significant impact on the health of patients in the future. So the take-home messages are that interventions to promote physical activity at the moment are quite variable in terms of their success, and we need to be developing these evidence-based interventions that target the unique determinants in different patient populations, and one size doesn't fit all. And then we can use motivation-based theories, but other theories as well, to try and understand behaviour and apply these to inform our interventions. And I think that's everything. I'm happy to take any questions, and thank you for listening.
Thanks, Sally. So next up we have Dr. Fiona Gillison, who's come from the University of Bath. And again, similar to, we're talking about how to translate theory into interventions and real-world practice. Thanks, Fiona.
Thanks very much. As Ian said, I've come from the University of Bath. I'm a health psychologist, and I did about 8 or 9 years working outside academia before I did my PhD. So I have a real interest in applying these theories to practice and actually getting involved in those realities that stop things working quite so well. So my former PhD supervisor will always remind me that until he worked with me, he'd never had a paper rejected. He thinks that's a bad thing. I think that's a good thing, because the sort of research that I'm doing does get messy and often doesn't work quite as you would want to do it. But I think that's what those of us who have worked in the field know is actually the case. Now, my title is about learning from what goes wrong, which really stems from the fact that when I asked Ian what he wanted for this talk, he said he wanted new data, which put me in a bit of a situation, because both of the new studies that I haven't yet presented didn't really go to plan. So today is me celebrating that, really, and trying to think about what we've learned from them not going to plan that might be useful for others trying to apply things themselves. And just to follow on from this lady's comments earlier, I work in a public health setting, in a preventive setting. I'm talking about physical activity promotion today, but I also work in obesity prevention, which is obviously very much related, and have done some work in smoking cessation. When I worked in the NHS, it was in smoking cessation. So yes, there are commonalities across these different settings, which are useful to reflect on. Okay, so the issue that I'm talking about, picking up from where Sally very helpfully left off, is this. So we know that motivation is normally associated with physical activity or with health behaviours. Not in all cases, but usually if you look at the association, it's there. And if we measured our motivation in this room now, and then which of us have done physical activity in the last couple of weeks, we'd probably find that link. We also know something about how to change motivation and what are the determinants. So it's looking into this black box. And if I'd been doing this talk 5 or so years ago, I think I would have been talking much more formulaically about the systematic coding of what it is that goes into an intervention. So Sally was talking about autonomy support, and we've done a lot of work to, in UCL there's been a lot of work to try and specify what these different behaviour change techniques are. We've done some work to try and specify what actually people are doing when they're being autonomy supportive, and the different specific techniques that you might use. And we're getting quite good at describing what we do now. And I think that does advance the field, but it isn't the be-all and end-all. What I'm looking at, really, which is what we know less about, is why sometimes we can change we can change some of these influences, so the determinants of motivation, and sometimes we can't. And why, when we do manage to change those determinants, so sometimes if we do manage to promote autonomy, let's say, autonomous motivation, sometimes that's enough to change people's behaviours, and sometimes it isn't. So I'm very attached to my picture here of leading a horse to water and trying to make it drink. So the sort of questions that we're looking at is, why will the horse come to water sometimes and other times it digs its heels in and it won't? And when we get it to water, why will it sometimes drink and sometimes it won't? And I think it's more difficult to do with physical activity and complex health behaviours than it is with a horse. And yet we still don't know about the horse. Anyway, so these are the 2 studies that I'm going to talk about, which are the ones that didn't go as planned. So they're on a different scale as well, which I think is interesting to look at, and that money and resource behind your studies isn't everything. So the first one was a £1 million public health research grant funded by the NIHR. I didn't lead it. It was led by Suzanne Audrey, who's an experienced trial leader over at the University of Bristol. But we worked with her to be the Bath arm of a trial, and there was also an arm in Swansea. And that intervention was about trying to promote active transport, active travel, walking in particular, by using a peer support approach within workplaces. So it gets back to this idea we were talking about, that we can't get health professionals to treat everybody, to talk to everybody. So how do we get this more dissipated amongst the community? And one way might be through getting workplaces to be a bit more positively involved. And then the second one was a PhD student of mine who is from Mexico, submitting her thesis tomorrow, hopefully, about what are the, she wanted to look at what are the biggest predictors of obesity, and she also looked at physical activity as part of that, and which would we target through an intervention based in schools. So this one was more exploratory. So I'll tell you a bit about each of these 2 studies, and then draw together some of the findings that might be the things that we've learned from not going to plan. So the first intervention as a starting point. So there is no reason that we think this shouldn't have worked. It was based on a feasibility study that had also been run quite intensively. There was a lot of engagement with members of the public who were participants and with stakeholders who were the employers. And a preliminary feasibility and pilot study shows that it had potential for good effect and that people could do it. So we were buoyed on by that, got some more money from the PHR to do this across 3 different areas. And as you see, we recruited 87 workplaces, which was no mean feat. Not a huge number of participants, so it was less popular within those workplaces than we thought, but nonetheless. And what we did was we trained up a walk-to-work champion within each of those workplaces to provide some support to people to get going in changing their mode of transport from the car mostly to walking to work. So we didn't train them, leading on from the other conversation, we didn't train them for long in how to be autonomy supportive, but we did have materials and a protocol that was about providing choice and getting the individual people to nominate how they're going to make that change. Are they going to change to a bus and walking? Are they going to park somewhere else and do partial walking, or are they going to walk the whole way? Are they going to do it a couple of times a week? So on and so forth. So it was designed to be autonomy supportive, but we didn't give these people intensive training. And the idea was that they would provide that supported by us, and that would be a way that would be scalable. So we had a logic model. So as I mentioned before, a few years ago, we were less good at specifying exactly what is going into these interventions. And as you can see, there were a few behaviour change techniques that we included. So there was goal setting and review. So the participants were asked to nominate goals in a workbook, and they reviewed this with the Walk to Work champion. We provided them information on the link between health and behaviour. I don't know if any of you have seen that 24 hours video, which is done at speed, where somebody's drawing really good cartoons of how it benefits your health. So we made everybody watch that. We did some barrier identification. What are you going to do when it rains? Self-monitoring, everybody had a pedometer. And then social support was really meant to be provided by the fact that you would be doing this alongside your peers in the workplace with support of this champion. That was the theory. We thought this would impact on motivation for walking to work, barrier self-efficacy, so confidence in overcoming those barriers, and also habit. We're going to hear a bit more about automatic processing this afternoon, but the very fact that this is walking to work, which is something that you do every day, that is at a certain time of day, so it's very easily queued up, means that it could become habitual, so that it's not a decision you have to make every day, you just do it. And we thought this would have a positive impact on the number of journeys you took on foot, and the amount of moderate activity you got during that actual commute, but also overall over the day. And I think what I wanted to flag, that we'll come back to later, is that a key part of this intervention that isn't really reflected in all of this theoretical background is the fact that being delivered by these workplace champions was really crucial to whether or not this worked. So what did we find? Well, the mean difference in physical activity was 0.3 of a minute a day, which I don't think I need to tell you was not significant. In fact, the amount of moderate activity that people got in the commute was slightly lower in the intervention group. Again, not significant, but for those who like a statistic, the confidence interval of that finding was below 0, which suggests that there was a disadvantage to be in the intervention group slightly. And we had no positive effect on those psychosocial mediators, so the autonomous motivation, the self-efficacy, or the habit, which was really disappointing because this was a huge undertaking, a lot of work, and really we made every effort to make sure that protocol, or our protocol, was adhered to. So once we'd picked ourselves up off the floor, and also from the rejections from our paper, from not even the highest ranking journals, obviously, any journal editor is very welcome to turn your paper down, but it is a problem when you have a trial that was at this scale, that has been invested into that degree by our public money, that you can't get published because it's a null result. But that's another story for another time. We've got it out there now. So we thought, well, what do we learn from this? So the first thing we wanted to look at is whether we'd picked the wrong things to try and target. So we looked at the associations between motivation, habit and self-efficacy and our behavioural outcomes, and found that there was some association there. So particularly autonomous motivation and that strength of habit did predict how often people walk to work. It's just it wasn't any thanks to us, because we hadn't managed to influence motivation or habit. But those things still look like they're important and they're worth targeting. But why didn't it work? Well, in our heart of hearts, we think it didn't work because most people, or a lot of people, didn't really get the intervention. These Walk to Work champions, some of them were nominated by their employers, some of them volunteered, some of them were really enthusiastic, already very active people, which some of the less active participants told us in the interviews that may have been a little bit off-putting. But also they had other things going on. So we have one very famous Walk to Work champion called Anthony. I won't tell you where he works. We thought he was going to be the best because he was so enthusiastic when we were pitching the trial to him. But when we went back to follow up 3 months later to give him a bit of support, we walked into his office and we just saw by his desk the box of all the pedometers and all the workbooks that all of our participants should have had the day after we last saw him. So this was a whole swathe of people in a large employers who were on our baseline. We'd done all our baseline measures, so they were in the trial and the intervention group. They hadn't had a thing. And he was enthusiastic. But other things had gotten in the way. So we think that's where we fell down. They didn't get that intervention. What we didn't do, of course, there is we were really focused on motivating individual people in walking to work. And we had all these behaviour change techniques to do that. We'd done really very little, just a 2-hour training session to try and motivate these Walk to Work champions. That is where we fell down. But also when we talked to the individuals, the people that were walking to work, because this did really work for some people. I'm telling you a negative story here, but for some people it was really, really changed how they were. But for others, they said they started well, but other things, other motivations got in the way. Motivation to save time, to get up later. Because walking to work isn't normally, for all of us, you don't walk to work and back every day and then life starts. You do things on the way or on the way back. So it's not that simple a behaviour to change. So that is the first study, and we'll reflect on that in a moment. And then on to the second one. So this was a PhD studentship, somebody coming over from Mexico, where obesity rates, particularly in children and adolescents, are even higher than they are here. So to Gabby, who came over to do this PhD, we looked like a good news story, and there's lots going on in our schools. So she wanted to come over here and learn from us what she could do to take back home. And we discussed, as we all know, that you can't just take an intervention off the shelf that works in one setting and take it somewhere else, particularly not from the UK, a high-income nation, and take it over to Mexico. It's hard to do it even within the UK. So the first step in her PhD really was to look at what's going on for Mexican adolescents, what seems to be predicting this level of obesity, this level of physical activity. So she went back to Mexico, recruited 6 schools, and set about trying to take a lot of anthropometric, well, I've started on a word that I wish I hadn't put down, anthropometric measures. She measured them. We had accelerometers for most of them, although we had trouble getting these to work and getting support when she was over in Mexico, and measuring the psychometric, some of the factors that were around the motivation for physical activity in particular. We've been scarred before by trying to measure motivation towards too many things. So motivations towards healthy eating, for example, are quite difficult to do because you can't get the specificity that you really need. But for physical activity, we thought that would be a bit more straightforward, just to see what was happening there. And I appreciate this is going to be too small for you to see. So really what you're focusing on here are the big green lines rather than anything else. So this is the model that we were testing, that Gabby was testing on the physical the predictors of physical activity in particular in her set of Mexican adolescents. So on the left-hand side for you, we have need support. So that's one of the factors, I think Sally mentioned, that's going to contribute towards forming this autonomous motivation towards physical activity. And again, this is just cross-sectional, so we're just looking at the associations rather than influencing anything yet. And she measured this from the support from parents, from friends, and from teachers. And all of these showed a positive effect on how that student was supported in terms of the factors that are going to underpin their motivation. What you would see if you had eagle eyes is that friends and parents had a much stronger effect than teachers did. And we'll come back to that, because this was one way in that Mexico is very different from this country is the absence of PE teachers, even in secondary school. These are 13 to 15-year-olds. But also the role that PE has and how that is interpreted by the teachers. If they had this positive need support, they had their needs satisfied, then they did indeed have a higher level of autonomous motivation. They also had some controlled motivation as well. So controlled motivation that we haven't heard so much about would be doing things for extrinsic reasons. So you're doing it to gain reward or to avoid punishment, perhaps. Or you're doing it to feel good about yourself, so that others feel good about you, rather than for your own personal reasons. And it's fairly normal, theoretically, for that to be boosted to a lesser degree than autonomous motivation. And sometimes it can help that initiation, even if it isn't useful for long term. But what you will see from this chart is an absence of nice green lines here, in terms of the association between motivation, whether it's controlled or whether it's autonomous, and physical activity. And I can reassure you that Gabby has tried every permutation of how you could measure and describe physical activity just to look for what effect this had, whether it's light physical activity, moderate to vigorous, moderate, using different cut-off scores for the accelerometers, and she's got sedentary time here as well, and there was just no association, which is unusual. It's not unheard of, but it's unusual because normally there is that link. Luckily, she did some focus groups with these same young people to try and get some insight into why it may be that there's this attenuated relationship between motivation and behaviour. And there were 3 themes that came out of these focus groups. She did 2 in each school, single sex, but a mix of children who were scoring high and low on physical activity levels. And some of these look very familiar to what we'd find in UK kids. So, understanding the health-behaviour link, they were pretty good at telling us what it meant to be healthy. So you can see here, very articulately, one child saying, well, it's playing soccer and eating chopped fruit. That's what it is to be healthy. And he's not really wrong. We also see at the bottom here, social support. So they recognised that if their friends were doing physical activity, then it made it much more attractive to them. They liked to, and they did it for that reason. If their friends wanted to stay home and watch TV, then they weren't going to argue with that. That's what they would do instead. So there was a real strong association, which we see here as well. But the one that really differed, that we think might have something to say about this lack of a relationship, was this idea that they felt they had a really restricted life. So in Mexico City, and it may not be in the rest of Mexico, so I think we have to just talk about Mexico City, the schools are very poor, and largely the people there don't have a lot of money. The schools are sufficiently poor, and there are a few of them, that they have 2 shifts. So they teach 2 cohorts of children, one in the morning, one in the afternoon. So as much as anything, that means your day is packed. It also means there's no opportunity for after-school activities. And they're also quite shabby, and there are a lot of rules about not running in the corridors, and teachers trying to stop children from being active at break times. That's what they were discussing. It's also a very unsafe city, so there were very few children who were allowed to get to school and back on their own. Active commuting to school was discouraged, and when they got home, they found that their parents would really like them just to stay home, do their homework, do some chores, and not go out. So there was a couple of children talking about being cared for by their grandparents who were too scared to take them to the park in the afternoon. Now, this is peculiar to Mexico City maybe, but actually it's probably not that different from some areas in the UK where there is a high level of disadvantage, where there are unsafe communities. So in a way it gives us a more extreme version of what we might find at home. So what we think, because we have checked and double-checked all our figures, is that something about this context is getting in the way of children being able to act on that motivation in order to be active. And as I mentioned, this is likely to be the case in some populations and in some areas of the UK too. And when that happens, really, which is unlucky for Gabby, because she wanted to do a motivational intervention, she's not going to get very far with trying to promote the motivation of those children. Because there was a range, as we would see in UK schools, of children with high and lower levels of motivation. It wasn't that they were all at one end or the other. But she's not going to get very far if there is no relationship. So she needs to do something with the environment as well. That's not to say you can just do the environment, because we've seen it before in the UK. If you build a leisure centre in a deprived neighbourhood, people in the deprived neighbourhood don't tend to use it as much as those that drive in from the less deprived neighbourhood. So environment isn't everything. But what it does remind me of is all of these discussions that you may be involved in, certainly people who are working in practice, about this systems level approach. Certainly my understanding is that if you're at any sort of public health related conference or event at the moment, it is the law to mention the whole system approach. And I think it's really interesting for us who are psychologists to think about how does motivation and this more individual level approach fit into that whole system. So I think that's worth discussing as well. So those were the two studies that we carried out that didn't give us the findings that we wanted. What do we learn from those? Well, I think there are three things that are useful to discuss. Firstly, around implementation. So we think the designs were okay. We designed these based on theory. We made sure that we didn't fall down quite so many hurdles that Sally was talking about. So it was a whole theory approach, but it wasn't implemented very well by the people that we asked to implement it. And this we see often in other areas. So when I used to work in smoking cessation, there was a big push to try and ask midwives to provide smoking cessation advice. I think things have changed. There's been a second wave of doing that since. But at the time, that really didn't work very well. We were pouring money into that. The government was trying to invest in that when the evidence showed that it didn't work. And what midwives were saying is that it wasn't their job particularly, and actually they felt it compromised their relationship with the patient. So while they could see the worth in getting pregnant women to stop smoking, actually if you gave them that role, it was a real conflict between that relationship with the one which they felt was more important. So we need to think about how we're implementing and who we're implementing those interventions. There's also something about, are we targeting the right thing? And by the thing, it could be the person. So are we targeting the right people? Who needs to be motivated? It's not just the people at the end of the line, but the people in the middle of the line. And also thinking about competing motives. So in the active travel example, is there something we can do that might help to bump active travel up the priority list of people when they've got these other motives that we know are competing for their attention too? And then finally, as mentioned, there is this idea of the context. And I think as you mentioned earlier, talking about Sally, you were talking about if we have interventions in primary care, which I think are very different from public health, because people have a very different relationship with their health when they've had some sort of health threat, and they get much quicker feedback. In these sort of environments, you've got people who aren't ill and aren't necessarily going to feel an immediate benefit from being more active, and yet we're trying to do it, trying to get them to change that for their health. So looking at changing that context so that it is a bit more relevant to people, that they may want to get a little bit more active. So just thinking about this idea of who we should target and who we should motivate, and getting very critical really about our intervention. We attempted to motivate these workplace champions, as I mentioned before, by selling them the health benefits of a more active workforce. And that was really motivating for the employers themselves, the people in charge. That's why they let us in the door. But actually, the people who ended up delivering the intervention were nominated, or they were tended to be lower down the pecking order. Some of them volunteered, some of them didn't, as I mentioned. But actually, it was no use giving them a health-related agenda, because they're not responsible for the productivity of that company, and they aren't going to personally benefit from the health benefits of either the individual or the company. So could we have done something better for that? Other workplace activities, things that they are performance managed on, are much more rewarding. And that's not to say that they didn't care. It's just when push comes to shove and you're busy, that might be what you choose to do or not to do. We had one really great example of a small workplace where everybody did the intervention, and there the champion went above and beyond the call of duty because she could see what was happening, she could see this working, and she instigated all sorts of additional ways of supporting everybody to do it together. Whereas in the larger workplaces, it was much harder to get that buy-in, because the person who was the champion may be in a different building, in a different site from people who had signed up for the trial. They got no positive feedback. It was difficult. It was just another thing that they couldn't necessarily see working. So you can see how that would slip. So actually, we think we need a whole behaviour change intervention that is not around health and not around benefits of the employer, to actually get those people doing it. Or else we change the people that do it, like the midwives example. Maybe we should let them have that relationship with with the mother, and somebody else needs to do that. And then I think I've gone over this enough at the bottom, which is the point about the individuals that we were working with. We tried to market the different benefits of active travel, so we didn't just go down the health route. We talked about convenience, we talked about cost and other factors, but actually the places where it worked the best were places where they were cutting down on car parking, or there was difficulty with car parking, or there were other external motivators at play as well. So I don't think we can always influence the competing motives, but actually knowing them that they're there is something that we can work with that population to see how do we make this more attractive. Coming back to this whole systems approach, a couple of my colleagues have been a bit disheartened, thinking, well, if we're now saying that we have to tackle the whole system, what is the place for psychology? Is it still relevant? Are motivational interventions in the public health scale still relevant? And I think they are. So models such as self-determination theory tell us about the social environment, and we have often chosen to interpret that as the environment around you. So in the example of our Mexican PhD, we chose to study that in terms of parents, peers and teachers, but actually it is the context that you live in. So I did some work with a colleague in Maastricht a few years ago, where they had a very different level of obesity than we had here, and we were looking at people's perceptions of what is a normal healthy weight in the UK on panel data compared with the Netherlands, and the pressures to conform to that healthy weight. And what we found was that there was a significantly different amount of perceived pressure to conform to a healthy weight, which is a very controlling sort of motivation, not autonomous at all. That was much higher in the UK than it is in the Netherlands. And the people in the Netherlands didn't feel that you had to get to such a small weight as we did in the UK. So what I'm trying to signal with that is that that's also the social environment. That whether it's from people immediately around us or elsewhere, we're feeling that extra pressure to conform to lose weight in this country, and that's part of our motivation towards doing it and can affect motivation for physical activity. So let's think bigger. Let's think about what we've got to say about motivation at that policy level. We do need individual processes as part of the system. It's difficult if you get people motivated and if you do use brief advice to try and get people to think about changing their behaviour. If we know that they need more input than brief advice, then we've got to provide it. So if we think back to smoking, which is one of the great successes of our time, really, the smoking policy, and certainly that was a system-wide approach. Getting GPs to refer people to stop smoking clinics was a real milestone in at least getting those services off the ground. And GPs early on wouldn't do it because they didn't have trust in the smoking cessation services or they didn't know about them. But once they are there and they are effective and you can sing about them and tell them about and tell people about them, GPs were really keen to transfer to refer people because it meant that they could have a shorter conversation, that they felt confident raising it because they didn't then have to deal with the whole can of worms for themselves and they could refer on. So as those individual level approaches to promote physical activity, to promote weight maintenance, because the two are often entwined, they are important if we want to start getting other people having the conversation, raising the topic. But motivational theory, I think, can also be useful in terms of how we look at policy. And this is my final real slide, really, which is less about research that we've done and more about thinking about how we can challenge ourselves to use motivation at this whole systems approach. So this is these 6 things are part of the Empower framework, which came out of people's efforts to try and say, right, we know that smoking cessation was a fantastic success. Those smoking rates have really gone down. What is it that we did? And can we translate that to other domains? So in the smoking domain, they talked about routine monitoring and surveillance. Do we know who's smoking and where and how many? We have some of that in the physical activity domain. So I looked at this in detail a few years ago with a colleague, but not much of that is based on objective data. So perhaps we're not very sure what our starting point is. They did health protection interventions in smoking, which is definitely easier. Obviously, smoking and physical activity are completely different behaviours, and a lot of the reason why people who introduced policies such as smoke-free, which is a pretty dramatic policy, why they thought that was so easily accepted was because this idea that we have to protect non-smokers from passive smoking is really compelling. I have it by a reliable rumour that only 6 prosecutions were made against companies who didn't ban smoking in their workplaces when the ban was introduced. It's probably more than that who flouted the ban, but it's very, very small. There was very little kickback. And part of that is because smokers were convinced that actually this was being done in a way that supported their values. Just because I'm a smoker doesn't mean I don't care about my friends and family. And so they were able to introduce these health protective elements without too much pushback. Certainly, they wouldn't have been able to do that probably 10 years earlier. It is a process of changing minds first. So it's a bit tricky to think what we can do in terms of health protection to promote physical activity, but not impossible. Certainly in the interviews that we had with people in Bristol and Bath and Swindon about why they managed to start off walking to work and then petered out, pollution, unpleasantness with traffic, these sort of feelings about it really not being a very pleasant thing to do to walk to work came up quite a lot. So if we can protect people from air pollution, if we can have segregated pedestrian and cycle routes, that might do something to make people feel that their health is being protected rather than harmed by walking to work, making it easier. It's hard anyway, we know that, to do something effortful like take up physical activity, so the more barriers we can reduce, the better. In smoking there was offering of support, and we certainly do that with physical activity. So at the community level, things like exercise referral services, although usually there is a clinical reason to be referred to that. Often the clinical reason is obesity, and as we know that nearly 2/3 of adults are now obese, I would say that's pretty much a community-based intervention rather than clinical population. And this idea of brief advice that we've mentioned. Health messaging is also important. So in smoking, there was a lot of fear appeal with pictures of blackened lungs and cigarettes dripping fat that you'd probably be familiar with, and that goes on. Fear appeal is less useful for something that is about promoting the uptake of something positive, like physical activity, but there are other ways that we can do that. So the This Girl Can campaign was an interesting example of trying to promote physical activity to non-slim fit bodies, or not, maybe fit but not so slim. And also there are some nice posters about with older adults swimming in swimming pools to try and promote physical activity to older adults. But we've got a lot to contribute about health messaging from a motivational perspective. And some of that is about learning from when things go wrong, again, in those situations. So a lot of you look old enough to remember when Jamie Oliver went into schools to try and take out turkey Twizzlers and improve that with school lunches. So he did this a while back before he got to be quite as famous as he is now. But the big news on that was not that Jamie Oliver had gone in and solved school lunches, was that the response to that from parents was that they went and fed beef burgers through the fences in the lunch times. I think that's a brilliant example. It's an example of reactance to a policy that was really well intended. And, he threw up his hands. Why would parents react like that when all I'm doing is trying to improve school lunches and the health of their children? Who wouldn't want that? But actually he hadn't done it properly. He hadn't engaged the parents, and I'm not really judging Jamie now, but this is an example. Because they felt that he had crushed their autonomy. He had made decisions beyond them that they hadn't been consulted with. They were scared, they said, that their children were getting 3 or 4 lettuce leaves for lunch and therefore going hungry. And particularly in the neighbourhood he was in, feeding your children so they don't feel hungry was a key priority, a key driver and a key motivation for how these parents were feeding their children. So he was conflicting with that. And so that's the action that they took. And we can look at other policies that introduce reactance. So I work a lot with the National Child Measuring Programme, which is where children in reception year and in year 6 are weighed and measured. And if they are overweight or very overweight, parents often get a letter informing them of this and inviting them to discuss getting their children more active and changing healthy eating. Now, I don't think you could write the letter more nicely than it is written. The school nurse team spends hours, and the Public Health England, trying to get that as supportively as possible, and yet every year we get the Daily Mail messages of parents being really upset by that. So it's another one that we could think about. Can we contribute some motivational theory to see how can we make that more of an autonomy supportive experience than not? I will wind up, sorry Ian, I've been going on. And the same thing, we can look at legislation, we can look at financial and economic approaches. How might motivational theory, in terms of particularly financial examples. Incentives we've mentioned briefly only seem to work short term if they're financial. You can use other incentives maybe a bit more helpfully. But look at those from a motivational perspective. So I don't think we've tapped as much as we can from motivation. So just to wind up, that was more of a hobby horse, but the key points that I wanted to make from the interventions that I presented were that we need to treat the training of staff seriously as we do the intervention itself, especially when we're not using health professionals or people with training. We need to monitor what has actually been delivered. We should have gone into Anthony's office earlier than 3 months to check that he had handed those out. We maybe need to look at combining environmental support with motivational interventions, but that could be in terms of the social environment, the culture, not just more structural things. And we shouldn't assume that we know what motivates people the most. And if we can engage with people more about what is their priority at that moment, we might be better at tailoring our interventions in a way that feel relevant to them. Thank you very much. Sorry, a bit longer.
Thanks, Fiona. We've got Professor Mark Connor from the University of Leeds who's come down. And in the first two talks there was a big self-determination theory emphasis in that talk. I don't think you're going to be talking too much about it. So a slight change of a theoretical approach and focus on intentions and how they can transform into behaviour. Over to you, Mark.
That's right. Thanks, Ian, and thanks everyone for coming. So I'm going to talk about motivation and behaviour. I'm going to focus on goal intentions as a key measure of motivation. So I'll show you what sort of measures they are in a minute. And then I'm going to focus on all sorts of things that moderate this relationship between intentions and behaviour, and also something about the antecedents of intention. So I think both Sally and Fiona have touched on these things. Their focus, I think, was more practical. Mine's more the theory end. So I'm missing out on that sort of messy element of dealing with people a little bit. So I can present some neater findings, but they may not stand up when you actually apply them in the real world. Here's the overview. So I'll start by just talking about motivation and intentions, and I'll basically be saying motivation equals intentions. Intentions aren't necessarily a perfect measure of motivation, but they're probably the best we've got at the moment, and there's no sign of anything coming along that's better. I'll talk a little bit about antecedents of intentions, focusing on some theoretical stuff. Who's heard of the theory of planned behaviour? So most people. Who's heard of the reasoned action approach? Okay, that's good. So there's a bit of a mixture. So I'll whiz through the theory of planned behaviour stuff and talk a bit more about the reasoned action approach. I'll then talk about the relationship between intentions and behaviour. Who's heard of the intention behaviour gap? Yeah, most people. So I'll focus on that sort of idea and things that influence it, and particularly on a bunch of moderators of the intention behaviour relationship. So what sort of things ensure that intentions do map on to behaviour? And this is the new bit that Ian asked for, the sort of recent research that's focused on that, and then some very brief conclusions at the end. Okay, so basically measures of motivation assess on the degree or strength of motivation. So you ask people about how strong they intend to do something. Do they very strongly intend to do it? Do they not very strongly intend to do it? That's our classic measure of motivation. We heard about autonomous motivation, which slightly twists that to be, well, what's the sort of basis or reason for you wanting to do this? But most research in this area focuses on things like intention questions, desire questions, effort questions, planning questions, commitment questions, and expectations. And here's a sort of just a list of items that you might use to measure something like eating fruit as part of your midday meal. So I'm not sure whether this is a manipulation of whether you'll actually go on to eat fruit later or not, but we'll see. So classic things are, I intend to do this, or I plan to do this. So they're standard sort of intention items. And strength is just basically the idea of, well, where are you on this scale? And usually it's measured as extremity, the distance from the midpoint. So this side would be stronger and stronger intentions not to do it. This side would be stronger and stronger intentions to do it. That's what we mean by strength of motivation in many of these studies, or strength of intentions. There's also measures like desire. So there's some theoretical work saying the thing you desire lead to your intentions to act. And then a third one that I'll touch on a bit later are expectation questions. So, do you think you will do this? And the idea is that this is probably a mixture of your intention and then your self-efficacy or your perceived behavioural control. Because we don't expect to do things that we don't think we have any control over. I might intend to be a world-class chess champion, but I don't expect to become one. Okay, so those are the different measures. They're generally very highly correlated. So if you get Combax alpha of those sorts of scales, 0.97 and above is pretty common. It's very hard to distinguish them. But theoretically, it's easy to see why intentions as a measure of motivation might drive behaviour more than expectation. Expectation, it's hard to see how it drives behaviour. It might be reflective of what subsequently happens, but it's hard to see as a theoretical determinant of behaviour. So that's my first bit. I'm going to now go on and talk about antecedents of intentions in models like the theory of planned behaviour and the reason action approach. And I'll go through this pretty quickly because it sounds like most of you are pretty familiar with this stuff. And I'll focus on meta-analytic data, but also sort of more interested in intervention studies. So correlation studies are all well and good, but unless we show that if you change that construct, intention, and you have an impact on behaviour, then we're not so interested in it. Okay, so this is the theory of planned behaviour that most of you are familiar with. It's a mediation model. It's developed in the area of attitudes. The assumption is the intentions are the key determinant of behaviour. The more recent development is this idea that previous applications of the model talked about self-efficacy or perceived behavioural control being another predictor. More recent developments talk about it as a moderator of the intention-behaviour relationship. So intentions will only predict behaviour when you have lots of efficacy or lots of control. Three determinants of your intentions: your overall attitude, your norms, and your perceived behavioural control. So this is an evaluation of the behaviour. This is the idea of social norms, what other people want you to do or think. And then this is this idea of whether you actually have control over the behaviour. And this one's a bit messy in that there's some degree of conceptual overlap between these two. It's suggested that self-efficacy might be such a good predictor of behaviour because basically it's also tapping your motivation. If we look at meta-analyses of the theory of planned behaviours, here's one we did back in 2011, then these are the sorts of correlations between intentions and attitudes, subjective norms, perceived behavioural control, and then we've also got in there behavioural beliefs that underlie attitudes, normative beliefs that underlie subjective norms, and control beliefs that underlie perceived behavioural control, and then also past behaviour. And there's this metric down the bottom in terms of how you might interpret that. So correlation 0.1 is a small effect, 3's medium, 5's a large effect size. So we're talking about fairly large effect sizes in terms of the antecedents of intentions. And the strongest ones seem to be perceived behavioural control or self-efficacy and attitude. But note, past behaviour is also a key determinant of people's intentions. Okay, so that's that bit. What about experimental evidence? So we've got the correlational evidence. How does the experimental evidence map onto that? So here we've got data from that same set of meta-analyses plus some others, and then some other work by Pascal Sheeran, where they've got studies where they actually said, okay, let's look at studies that successfully change each of these components and see what that does to other concepts. So here we're looking at changing those antecedents and their impact on changing intentions. The next slide will do the same thing for changing behaviour. So what do we see? Well, these are D's this time, so we get large effects of attitude on intentions, fairly large effects of social norms and self-efficacy. But when you look at the experimental evidence, then not only does the effect size actually drop considerably, but it's also quite similar to the three concepts. So if you want to change intentions, it doesn't seem clear from the broad evidence whether it's best to focus on attitudes, norms or self-efficacy. They're all similarly effective in changing people's motivation or intention to act. If we look at predictions of behaviour, then the pattern's much the same. So intentions, clearly the strongest predictor of behaviour in correlational studies, followed by self-efficacy, but there is also effects for attitude and norms. If we look at the experimental evidence, then actually self-efficacy is the best thing for changing behaviour, followed by attitude, then intention, and then social norms. So if you just want to change behaviour, motivation's only one of the things that you actually might want to predict or actually to focus on. You might want to directly focus on attitude, social norms or self-efficacy. So that's not entirely consistent with what the theory of planned behaviour says. Okay, so that was the bit on the theory of planned behaviour, which you're all familiar with. This is the theory of reasoned action. Sorry, not the theory of reasoned action, the reasoned action approach, which is associated with Fishbein and Eisen, sometimes also called the two-factor model. You'll see it looks very similar. Basically, you've got intention and behaviour, and then you've got attitude split into 2 bits, norms split into 2 bits, and self-efficacy or perceived behavioural control split into 2 bits. So experiential attitude is just to do with feelings towards behaviour. Do you enjoy it or not? Instrumental attitudes are things to do with other sorts of outcomes you might associate with behaviour. So health outcomes is the classic one. Does physical activity actually lead to you? Do you expect it to lead to sort of more healthy outcomes? Whereas this one would be, do you expect to actually enjoy doing exercise? Norms are split into these injunctive and descriptive. So injunctive is this idea of just what you think others might want you to do. Do your friends want you to exercise? Your family want you to exercise? Whereas descriptive just refers to, do they do it or not? But it's your perception of whether they do it or not. And then PBC splits into these 2 rather confusing factors. One is capacity, which is to do with whether you think you have control over it, and one is to do with autonomy, whether you're autonomous in doing it. I'll show you some examples of that in a minute. Okay, here's another meta-analysis showing these effects. So I've just picked out the ones in terms of predicting intention. So you'll see we're back to correlation. So we've got medium to large effect sizes for instrumental attitude and affective attitude. And the interesting thing is that in terms of changing motivation, all this stuff we do about telling people about the health benefits, which would be an instrumental type attitude, are less powerful in driving motivation than are these affective attitudes, how the behaviour might actually make them feel. If we look at norms, similar sorts of effect sizes in the medium range for injunctive and descriptive norms. And then if we look at these other variables that I've relabeled this time, perceived control and self-efficacy. Self-efficacy is a good determinant of intention. Perceived control is not a good determinant. People haven't got a clue what you're talking about when you ask about perceived control. They just don't know what you mean by it. And conceptually, it's quite difficult to pull together what is meant by perceived control. Here's some regression data based on the same meta-analysis. So if you don't believe in meta-analysis, then this is really getting way beyond what you'll feel comfortable with. But basically, it just shows the idea of what happens when we look at all the predictors at once. So in terms of predicting intention, well, it's pretty much as you expect. All of the variables except perceived control are predictors of intention. The strongest are affective attitude by some way. But we've also got effects for instrumental attitude, injunctive and descriptive norms, and self-efficacy. If we looked at predicting behaviour, then we do get this main effect of intentions. So your motivation, your intention to act is the main thing that drives your behaviour, but you also get this direct effect of self-efficacy. And we don't get that moderation thing that Eisen claims should be going on, that intentions are only strong when self-efficacy is actually strong. But this last column is a really quite interesting one, I think, is that in that it shows that actually it's not just intentions that drive behaviour, and it's not just self-efficacy, but it also seems to be affective attitude and descriptive norms. And that's summarised in this slide, showing all these different pathways that might be going on. So although most of the effects of these antecedents of intention go through intentions, there do seem to be direct effects of descriptive norms on behaviour, experiential attitudes on behaviour, and capacity or self-efficacy on behaviour. So knowing that others are doing it might make you more likely to do it without thinking about whether you plan to do it. Enjoying the behaviour might make you more likely to do the behaviour independent of whether you plan to do it, whether you intend to do it or not. So there's some interesting potential pathways we could look at in future studies for how we might change behaviour without just focusing on motivation. Okay, so that's my first 2 bits. Third bit, the intention behaviour gap. So Most of you will come across this idea that intentions are only correlated about 0.5 with behaviour. So this means that 75% of the variance in behaviour is unexplained. And it depends on where you lie, I think, whether you're impressed by that or depressed by that. Intention's by far the strongest variable we know in predicting behaviour. It's the thing that comes out again and again as a strong predictor. But it's only explaining about 25% of the variability in behaviour. And that might just be because there's all sorts of things we don't know about that are predicting behaviour, or it might just be down to the fact that behaviour is not completely explainable. Everyone's situation is slightly different, context is going to have an effect, and we can't measure some of those influences. And this is usually summarised as this idea that it's not evenly spaced between intenders and not intenders in terms of who are acting consistently and not consistently. So if you look at the people who are inclined to act, then about 47% of them go on and act. So people who are intending to act, about half of them go on and do it. Whereas people who are not intending to act, only 7% of them do it. So very few people act not in accord with their intentions, do something when they didn't plan to do it. So most of the action is in this idea of why people who are inclined or motivated to do something don't go on and do it. And that's what I'm going to focus on for the rest of my talk. Okay, so what sort of things can we do that might influence this intention behaviour gap? So this is getting into something just a bit before we get into sort of direct moderators. Well, one thing that's quite interesting in this area is that just measuring people's intentions changes their behaviour. This is sometimes referred to as the question behaviour effect. Asking people their intentions may make it more salient in their mind and make them go on to do it. And there's quite a few studies demonstrating this. So there's this one that Gaston Godin and colleagues did on blood donation. So if you ask people about their intentions to donate blood, about 9% more of them do it than if they don't ask them about their intentions to donate blood. And there's a nice meta-analytic review by Chantel Wood at Sheffield showing that we get this consistent effect, particularly for self-predictions and intentions. But I just want to show you one example of this. So this is a study on cervical screening, pap testing, and it focuses on the idea of what happens if we measure motivation, but what happens if we measure some other things as well. And we're going to focus on the idea of anticipated regret. This is one slide that I'm particularly proud of. I found in a Swiss ski resort, and I think it's basically getting the idea of if you don't take out insurance for skiing, you might end up regretting doing it later because you might end up like this and not able to get at the toilet paper. Okay, so we've got women, about just over 4,000, allocated to one of three conditions. So they're getting their standard invitation for cervical smear. In the control condition, nothing else, and then we just see whether they attend or not. They're getting that, but they also then get a theory of planned behaviour questionnaire that asks them about intentions and some other variables, or they get a set of theory of planned behaviour questions plus questions that tap this idea of might they regret not going for it later. So it's trying to make regret salient. Here's what happens. So this is the intention to treat analysis, and basically what you see is that we get something like a 6% increase in 5 to 6% increase in attendance just by giving them a questionnaire about cervical screening. So the idea would be that it's something about actually making motivation or intentions to do it salient. And one of the analyses we subsequently do shows that it's actually only amongst the women who intend to go that you actually get this benefit and this increase in actual attendance. Measuring people's intentions when they don't intend to do it doesn't change their behaviour. But the interesting bit is this so-called per protocol analysis. If we just take the women who filled in the questionnaire and were clearly exposed to each of the different questions, we get this big difference between those who just got a theory of planned behaviour questionnaire and those who got that plus anticipated regret. 20+% increase in attendance rates by making regret salient. And this has been shown in a number of studies now that making regret salient to people can actually dramatically improve the intention behaviour relationship. So if you intend and I make regret for not exercising, not going for cervical screening salient for you, you might be more likely to follow through on your intentions. Okay, another factor that seems to influence the relationship between intentions and behaviour at the sort of antecedent end of things is what you base your intentions on. So we can base our intentions on, well, we think this exercise is good for us and it will lead to health, sort of attitudinal thing. We could base it on the idea of, well, we'll do it because others want us to do it or others are doing it. Or we could base it on this idea of anticipated affect. So we're doing it because if we don't do it, we might regret it. So we're going to screening because if we don't go, we think we might subsequently regret not going. And we've got a number of studies here. I think Fiona mentioned the idea of not being able to see it. I'm sure you can't see that. But the basic idea in this complex analysis is that if you base your intentions on regret, they're much more powerful determinants of a range of different behaviours than if you base it on your attitudes and your norms or any other factors. So basing your intentions on certain sorts of things might make them actually more powerful determinants of subsequent behaviour. Okay, so I've rushed through that bit, and mainly because I wanted to get to this bit. I want to talk to you about some moderators of the relationship between intention and behaviour that we've been spending the last few years actually looking at. And underlying this is one particular moderator that potentially explains the effects of all the others. And it's a rather simple one, really. So it's this idea of, well, intentions won't drive your behaviour unless they stay stable from when I measure them to the point at which you decide to act or not. If you've changed your mind, then you wouldn't expect intentions to drive your behaviour. But if they stay the same, you're still intending to exercise, you're still intending to go for cervical screening, you would hope it drives behaviour. And there's a series of studies that have looked at this idea of intention stability now, and I'm going to show you a couple of them. So here's some data from Connor and Godin back in 2007, just looking at a whole range of physical activity studies, and basically showing that when intentions are stable, they've stayed the same over a certain period of time, they're much more powerful predictors of behaviour than if there's evidence they've actually changed. So individuals who have stable intentions, they're the ones that are more likely to go on and act on their intentions. Here's one in the health domain, so that we're particularly pleased with because it shows these effects over quite prolonged periods of time, in this case 6 years. So here we measure a bunch of components of the theory of planned behaviour. We go back a month later, we measure them again, and then we go back 6 years later again and see whether they're actually performing healthy eating or not. And the bit to focus on is this bit at the bottom. So this is a moderation analysis, and this basically shows that if your intentions are stable, then your intentions are more likely to drive your behaviour, and your past behaviour is less likely to drive it. So a positive moderation effect here and a negative moderation effect here. So stable intentions can actually overcome habitual factors that we're going to hear more about this afternoon, and it can ensure that your intentions are more likely to be driving your future behaviour, even 6 years later. Okay, another study in this area, key study that I'll go through very quickly, is one by Pascal Schuren and Charles Abraham. They looked at a whole bunch of different moderators of these intention-behaviour relationships. So all sorts of factors that might change the relationship between your intentions and your subsequent behaviour. So they looked at how certain your intentions were. Are you sure you want to exercise? Are you sure you want to go for cycle screening? Are you sure you want to eat healthily? They looked at past behaviour. They looked at self-schema, anticipated regret, like we've seen a moment ago, attitudinal control, which is the basis of intentions, and then also intention stability. And one of the things they found from all those different studies was that although each of them were moderators of the intention-behaviour relationship, when you actually took account of all of them simultaneously, it's this one that explains the effect. So the fact that anticipated regret changes the relationship between your intentions and behaviour seems to be because what it does is it makes your intentions more stable. So if you think you're going to regret not going for that run, it makes your intentions more stable over time, and that leads to those intentions being more likely to drive your subsequent behaviour. So I'll skip through that bit. Okay, so I'm going to focus then now on 4 more factors that influence the relationship between intentions and behaviour. So these are these more recent studies. So one is sort of the idea of goal priorities. So if you prioritise a behaviour over others, does that make your intentions better predictors? Well, we hope so. Motivational coherence. So this is the idea of, well, are all the things that underlie your intentions coherent with one another? So is it the case that your attitudes are consistent with your norms, your attitudes are consistent with your perceived behavioural control, and your norms are consistent with your perceived behavioural control? So are they all similar or not? And we basically measure this as the within-person standard deviation of those different measures. So if they've got a small standard deviation, they're all very similar, or if they've got a large standard deviation, I think it will be fun, but I don't think I've got control over it. Or are they consistent with one another? Third one is this idea of degree of reasoned action. So this takes a very similar sort of view of the basis of intention, but it says, okay, how well can I predict an individual's intentions based on their norms, their attitudes, and their perceived behavioural control? If I can predict it well, then they've really thought through what they're actually going to do. If I can't predict it very well, they're telling me an intention that they haven't really thought through very closely. And then the last one, it relates to realistic intentions. So it's the idea of, are my goal intentions consistent with my expectations? So where they're consistent, we would argue that they're being realistic. Yeah, I think I'm going to do that. Where they're inconsistent, we're saying people are being unrealistic. They're either being optimistic or pessimistic in their intentions to actually engage in the behaviour. And I'll very quickly show you data from a set of studies demonstrating each of those things as moderators of the relationship between intentions and behaviour. So this is the first one, goal priorities. So this is a study we did back in 2016, and we've got 2 correlational studies and 2 experimental studies. So in the correlational studies, we just ask people about whether they intend to do something, and then whether they intend to prioritise that behaviour or not. So, and what we're interested in is when those 2 things converge, when I both intend to do it and I prioritise that behaviour. And that's what we get down to the bottom here. We show this idea that when someone prioritises a behaviour, I'm going to do this exercise, I'm going to do this going for cervical screening, then their intentions are much more likely to drive their behaviour. We also had 2 experimental studies. So the idea here was actually asking people to prioritise things. So tell us which of these behaviours you're going to prioritise, and then we're interested in the ones you prioritise, are intentions for those behaviours better predictors of whether you'll go and do it or not. And again, I won't show you the details, but basically you get this idea of intentions are, if I can find it, yeah, intentions are predictive of behaviour in the goal priority condition, but they're not in the control condition. So making people prioritise, in this case I think it was physical activity, makes them more likely to actually engage in it. If you ask them to deal with conflicts between that goal and another one, it doesn't work. So it's the prioritisation that seems to work in moderating this relationship between your intentions and your subsequent behaviour. So prioritisation is a key moderator of intention and behaviour. I think it's also interesting in that it's one of these few variables that starts talking about multiple behaviours. We don't just do one behaviour at a time, we do lots of behaviours in a day. So we don't just go for a run, we also try to eat healthily or not, we also go for screening or not. How do you actually put all these behaviours together? Well, models like the theory behind behaviour don't even try, they just focus on one behaviour at a time. Goal priority is one way of trying to bring those different things together. Say, well, okay, is this behaviour a priority for you? If it is, then your intentions seem to lead on to your behaviour. If it's not a priority, then actually you're not going to be able to change people's behaviours by targeting their intentions. So what this study suggests is that you need to both target prioritising things you want to change and the motivation itself, the intention. When you do both of those things, you might get change in actual behaviour. Okay, motivational coherence. So as I explained, this is this idea of whether the concepts that underlie your intention are consistent with one another, so they're all very similar, small within person standard deviation, or they're not. And the prediction would be where they're consistent, so the standard deviation is small, then your intentions would be more predictive of behaviour because they're based on a sort of more consistent basis. And I can't go into detail, but across 3 different studies, then we consistently find this idea that motivational coherence moderates the intention-behaviour relationship, such that the more coherent the concepts underlying your intentions are, the more your intentions drive your behaviour. Here's the simple slopes. Is everyone familiar with simple slopes? Anyone at all? No? 1 or 2? Okay, so this is just a diagrammatic way of presenting what I've just shown you. So we've got the relationship between intention and behaviour, and we've got it for different studies, and basically a steeper line indicates a stronger relationship of intentions on behaviour. A flat line like this says, well, it doesn't matter what your intention are, you still do the same amount of behaviour. So what we see consistently across studies is that the highly motivated, this dotted line, shows a strong relationship between intentions and behaviour for, I think this one's breastfeeding, this one's sports centre attendance, so we measured whether they went into sports centre using a swipe card, and you'll see that intentions were unrelated in the low coherent group, but strongly related in the high motivational coherence group. And then the last one was in relation to smoking initiation in adolescence. Okay, so that's motivational coherence. This one's degree of reasoned action. So here we're saying, okay, what we're interested in is how well an individual thinks through their intentions. Have they thought about the different bases underlying it? So what we do is we create a regression for each individual, predicting their intentions from their attitudes, their norms, their PBC, and then we have an idea of, well, either that's a high R or R squared value, or it's a small R or R squared value. So either we have high degree of reasoned action, they've thought through because their intentions do seem to be correlated with the underlying factors, or they're not. And it's when they're well thought through, we've got a high degree of reasoned action, that's when we expect intentions to drive behaviour. You can only test that sort of model across multiple behaviours. So this is one of these crazy multi-behaviour studies. So I think we've got 20 different behaviours here. We measure intentions, attitudes, norms, PBC in relation to each one, and then whether they say they actually do the behaviour. I think it's 1 month later. We do multiple regressions for each person, and then we feed in that R squared value as a moderator of the intention-behaviour relationship. And somewhere on there you'll find it. I think it's down the bottom here. So it's here. So we get a significant effect of reasoned action on the intention-behaviour relationship. And we also get this significant negative effect on habit. So again, like we saw earlier, degree of reasoned action both makes it something where your intentions are more likely to drive your behaviour, and your behaviour is less likely to be influenced by your past behaviour. So it's your intentions driving what you do, not what you've done in the past. Here's the simple slopes again, and what you'll see is actually that it's this line here where we get the steepest slope. So it's where we've got, sorry, this is looking at the interaction between the two, so I'll gloss over that for now because it gets a bit complicated. Okay, last one. I'm sure you've had enough of these different studies, is looking at realistic intentions. So, as I said before, the main idea here is that, well, if your intention's realistic, so you really expect to do it, is that intention more likely to drive your behaviour? Again, it's another multi-behaviour study, and we've got, I think, 4 different studies in this paper, and we again show this idea that it's an interaction between your goal realism and your intention that actually drives behaviour. When you're realistic, then your intentions drive your behaviour. I think we've got the simple slope showing that. So when you're not being very realistic, then behaviour is only weakly related to your underlying intentions. So high intentions is slightly more likely to perform the behaviour, but not an awful lot. When you've got high realism, so that's when your intentions are closely aligned with what you expect to do, then we get this really quite strong relationship between intention and subsequent behaviour. You do a lot more of the behaviour when you intend than when you don't intend. Okay, so conclusions. I've been through quite a few different studies, all making the same sort of point really, that first, intentions are our current best measure of motivation. We heard about autonomous motivation this morning. That would be seen as another moderator of the goal-intention-behaviour relationship. So I presented some correlational experimental studies supporting the importance of intention as probably our best proximal determinant of behaviour. So it's the variable still that seems to be most closely related to behaviour. And this is true in both correlational studies where you just measure it, preferably at two different time points, intentions and then later behaviour, but also when you change people's intentions, then it does seem to be the thing that drives people's subsequent behaviour. And I think this is so much so that we've been going around saying, well, if you don't get people motivated to do something, everything else doesn't matter. So most other interventions don't really matter unless you've got motivation. I think that's true for a lot of behaviours, not true for all behaviours. So certain habitual behaviours, then they seem to be operating independent of intentions, but an awful lot of behaviours that we're interested in, like physical activity, diet and drinking and smoking, then motivation seems to be a key thing to actually tackle, but then you might need to do something else after you've tackled motivation to ensure behaviour follows. Last thing, I went through a number of these moderators of the intention-behaviour relationship. I talked about some of these recent studies that we've been doing, but the key variable seems to be in this area seems to be stability. How do we make people's intentions more stable such that they can drive their subsequent behaviour? Okay, that's it. Thanks very much.
Thanks very much, Mark. So this afternoon we're going to the City of Steel for two talks now. The first one is Professor Madelynne Arden from Sheffield Hallam University. And as I said at the very beginning, I think this one will be a little bit different to the morning talks where we were talking about very conscious drivers of behaviour, conscious motives. To talk about habits and automaticity, specifically in the medication adherence field. Over to you.
Okay, thanks. Yeah, so I'm from the Centre for Behavioural Science and Applied Psychology at Sheffield Hallam, and we also work collaboratively with the University of Manchester in our Behavioural Science Consortium, where we do work with local authorities and public health and the like. So what I'm going to try to do is to talk a bit about medication adherence, and specifically in the context of a condition I've been working in over a number of years, cystic fibrosis, and an intervention that we've developed called CF Health Hub. I'm going to be talking about habits in the context of that, and all three of those are kind of linking in, hopefully, so that we're really talking about kind of maintenance of behaviour change here. So hopefully that will kind of come out as we're going through the talk. So for those of you who aren't familiar, I'll just kind of be whizzing into kind of cystic fibrosis and coming out and going in and coming out, and hopefully you can follow me. But cystic fibrosis affects around 10,500 people in the UK. It's a genetic condition, and a 40 gene basically causes there to be thick, sticky mucus in parts of the body. And that causes particular problems in the lungs, where that thick, sticky mucus builds up and makes bacterial infections more likely, which over time cause kind of progressive lung damage. So this kind of symptoms are coughs, wheezing, repeated chest infections. There is no cure at the moment, but treatments have dramatically changed the situation. So 50 years ago, children with CF didn't tend to live past kind of toddlerhood, and now the median survival is around 31 years. But treatment is really crucial. So what treatment is there? There are treatments it affects multiple organs in the body, but I'm really focusing on the lungs, and nebulizer treatment is one of the key ways that the kind of medical profession aims to keep the lungs of people with CF healthy. And it varies a bit what kind of treatment you have, but for a typical adult with CF, they would need to nebulize using a device like this 2 lots of antibiotics a day, and between 1 and 2 mucolytics, and that's a drug that thins out the mucus and allows the body to get rid of it. It's treatment every day for life, and it involves not just nebulizing, but for some people they have to mix their drugs and they have to wash and sterilize that equipment. It works though. There's evidence that people who collect 4 courses of a type of antibiotic were 60% less likely to be admitted to hospital for kind of rescue care. So they're receiving less lung damage. A kind of key thing about the project I've been working on is that we have objective measurement of adherence. So what we have is these kind of nebulizers, and they date and time stamp when treatments are taken. And patients have a hub that they plug in at home, and via magical Bluetooth that I don't really understand because I'm a psychologist, it goes through the sky and ends up on our web server. I don't know how that bit happens. But what that means is both patients and clinicians can look at their adherence data, and it's been objectively measured. Self-reported adherence to nebulizer treatments is around 80%, but when you use these really objective measures, there's a median of 36%, and we're consistently finding in our study, as well as Daniel's, that it's around there. This is a real-life quote from a reviewer. "It is unclear why adherence is so low if the condition is so unpleasant and life-threatening," which is really the point, isn't it? It is really surprising. Why? Well, logically, of course, you would take your treatment. Okay, so this is a theory that's used a lot in adherence, and this is the necessity and concerns framework, which basically says that patients are more likely to take their treatment if they perceive the necessity of it to be high and their concerns about it to be low. So the concerns might be things like side effects or things like that. So, you know, this kind of pros and cons type approach. Some data, this is from a pilot study, it's a relatively small sample, but across the bottom you might not be able to see, but on the left, these are people whose adherence is less than 50%, in the middle between 50 and 80, and on the right-hand side, adherence above 80%. And although there are some differences here in necessities and concerns, they're not kind of dramatically different in terms of, you know, so the low adherers and the medium adherers have pretty much the same perceived necessity, and the concerns are pretty consistent across the lot. So that's not really, for at least for these patients, kind of explaining what's going on. And I think one of the things is that kind of logical processing and weighing up of the pros and cons of taking your treatment is something that happens in what Kahneman would call system 2. There are other models that refer to this kind of dual process. So this is a kind of conscious, slow, effort, logical process that you might go through to decide whether or not you should be taking your treatment or whether or not you should be being physically active. But we also have system 1, and this is more instinctive and quick. It doesn't require effort, it's emotional and it's automatic. It's the reason why some people picked up cake when they knew that the fruit was better for them. Not many people, though, I noticed. And when we look at that same sample in terms of their motivation to hear, so these were single measures in a huge questionnaire, so we weren't able to use the kind of complexity of measures that Mark talked about earlier, but we talked about whether people wanted to take all their prescribed treatment and whether they were confident that they could take all their prescribed treatment in the next 2 weeks. So again, you can see there are a few differences. Certainly our lower adherence group seem to have less intentions to adhere and feel less confident. But again, there's not much difference between the people in the middle group and the people that are adhering really well in terms of who wants to adhere, if you like, their intentions to adhere. And it's probably because we know that people's lives are like this cat. So taking medication adherence isn't one thing that you're doing. You're living your life and you are trying to deal with all the things that it throws at you. So you haven't got time to make those slow, deliberative processes in system 2, and actually you're relying on system 1 to quickly deal with that issue. Everybody's enjoying that far too much. Okay, but we have a kind of way to access system 1, and that's potentially habits. So habits sit within system 1 and they're automatic. So I'll explain a little bit more. So what is a habit? So these are kind of some definitions. Gardner wrote a review about kind of habits quite recently. So a habit's prompted automatically by a situational cue, and it's a result of a learned cue behaviour association. It's formed through that repetition of behaviour in that specific context in relation to that specific cue. And then after that kind of repetition, that cue or context can activate that behaviour without awareness, without control, conscious control, without effort, and without that need to deliberate and think it through. So in kind of a graphical form, what we've got is probably goal-directed, though not all habits are created through goal-directed behaviour. But in the context of adherence, they probably are. People don't accidentally take medications. So people want to take their medication. There's some kind of cue or context that they link with that behaviour, that medication taking. And the idea for a habit formation is that there should be a reward. Then the repetition of those two things happening together then means that the cue, when you come up against it, produces an automatic impulse and you behave. So you adhere to your treatment. So it's that repetition, you learn that the things kind of go together and then one can result in the other. These are a little bit different to lay descriptions of habit. So this is some work, it's not been published yet actually, it was presented at a recent conference. So Daniel Brown and colleagues, this work was done in Australia, asked people what they thought habits were. And so members of the public talked about them in quite different ways. So they talked about habits being behaviours they did frequently. So I've got a habit for looking at my phone, or a habit at picking at food when I'm cooking. So these were things that they did frequently rather than necessarily being cued responses to something. They also talked about things that were typical for me. So I've got a habit of being green, so kind of environmental type behaviours, or I've got a bad habit in terms of my grammar. And they also talked about routines. So routines are similar to habit, but they haven't got that cue response structure. So you might have a morning routine where you tend to do the same kind of things before you go to work, but they're not necessarily kind of cued responses. So for example, I tend to have breakfast, but I don't get my bowl out and my spoon out in necessarily the same order. I don't choose the same breakfast cereal. So they're more routines than habits. So in terms of habits for treatment, what are we talking about? We're talking about habitual behaviours that are automatic, so you do them without thinking. They're cued by something, often in the environment, and they require less motivation and less effort to do. So for example, you might use your nebulizer after you've made your cup of tea first thing in the morning. Okay, so that's a kind of habit, that's when you always do it. In terms of habits in CF, this is the same kind of data set. So this was from a pilot study at baseline, and we asked people to complete something called the Self-Reported Behavioural Automaticity Index, which is a measure of habit strength. And then we've got those same categories. And you can see here that the high adherers had much stronger habits than the low adherers. And it was more of the kind of linear pattern that you might, kind of goes up, that you might expect to see. So some of you might be thinking, yeah, but you don't do stuff and not realise you've done it. It's not completely automatic. And I think this is something that Ben Gardner again has talked about recently, and that is whether we're talking about habits for initiating a behaviour or habits for executing a behaviour, and they're slightly different things. So we might be talking about picking up a nebulizer after we've put our kettle on, and that bit can be automatic. You can do it without thinking. But maybe this whole process might not be habitual. So you might have awareness of the fact you're mixing medication and going through these steps. So we might be talking about initiation rather than habits for the whole of these steps from one through to the other. And similarly, if we think about physical activity, you might get in from work and put on your gym clothes, but you probably would be aware that you've been running around the woods for a bit. That's not without awareness. The kinds of complexities of behaviour vary in whether they can be kind of truly habitual all the way through, but I think this is a good example. So you sit in the driver's seat of a car, you plug in your seatbelt, you turn on the engine. It's completely habitual. At no point when I do it, certainly, do I think about the pros and cons of being in an accident with a seatbelt on or not. I don't know whether I've done it to the point that if someone said to me, "Have you got your seatbelt on?" I'd have to check. It's just so habitual. So, kind of going back to our intervention, I'm going to kind of explain why our kind of conceptual framework and why we're using habits. So, we know that people with cystic fibrosis aren't taking as much treatment as ideally we would like them to do, and ideally they would like to do for most people. But as everybody said this morning, we're not going to get anywhere if people don't want to do it. So a kind of key part of our intervention is motivating people in the reflective ways that everybody's been talking about today. So we think that there are potentially a group of people who won't do their treatment. So these are the people that don't want to. It may be that they don't perceive the necessity of their treatment. It may be that they have some concerns. But if we can persuade them to do their treatment, and I'll show you how we've done that a bit later, hopefully we can get them to kind of start to make initiation attempts to try and increase their adherence. And then they may come across a whole host of barriers, things that get in the way, that we kind of called, for those of you who are familiar with it, the COM-B model, so capability, opportunity and motivation. So these are some of the barriers that get in the way. So things like not being very good at planning out your day, it's a capability barrier. Or opportunities might be that your employer hasn't given you permission to take your nebulizer in the workplace. So we work to kind of problem solve barriers so that we can kind of address the people that want to take their treatment that can't for some reason. And then we hope to, initially through self-regulation, enable people to repeat their treatment taking behaviour. Over time then, if we can get them to do that in the same context, that frequent repetition should enable them to create habits for treatment. And this taps into kind of automatic motivation, the kind of system 1 stuff, so that they can do that and hopefully be less likely to relapse. And I'll talk to you a bit about why we think that might be the case. So in terms of theoretical explanations for maintenance, so this was a recent review that looked at the kind of different theories that there were for why people might maintain a behaviour or not. So the first is maintenance motive. So people maintain a behaviour if they have a motive for doing so. So that might be they're satisfied with the outcomes of that behaviour. So it might be fun, they might feel better, that might be the kinds of things. Or it might be that they have a kind of new identity as somebody who does. So I am now a runner. Self-regulation is another way. So this is where people are monitoring and regulating and overcoming barriers to sustain their behaviour. Resources are about whether they have the physical and psychological resources, and if we can make them plentiful, then they're more likely to maintain their behaviour. Environmental and social influences, so this is the environment and social support to do that behaviour. And then finally, habit. So they now have a behavioural response to a cue that's habitual. So looking at these things for adherence then, so if we think about maintenance motives, this is somewhat problematic. So, and this is problematic in terms of that reward as well, actually, in terms of developing habits, but we may have some ways to address that. But in terms of satisfaction with adherence, so the first is health outcomes. So you'd want to be healthier if you're taking your treatment. For cystic fibrosis, the health outcomes are a long way from the treatment taking. Okay, so we're talking about kind of less days in hospital over years. It's quite difficult to realise that there are differences there. And even with symptoms, so cough and wheezing, it can be difficult to tell. So Rosie Martin is a PhD student of mine, and she's been tracking patients' symptoms, daily symptoms, with their objective adherence data, and there are very few obvious relationships between those two. So it's not even that people are kind of noticing symptom changes. So that's quite tricky as a maintenance motive. In terms of self-identity, that's possible. So people kind of identify as being a kind of treatment taker. And we have got some evidence that there is differences in the kind of identity of high adherers and low adherers from a qualitative study that we undertook. So high adherers identified as they were organised people. I'm an organised person. Lower adherers said they were rebellious risk takers. So that's quite challenging potentially to change, but there are potential ways to do that. Increasing resources is tricky, so we can do some problem solving, but this is people's lives with CF. They've got other stuff going on. We can't get rid of that. We don't want to get rid of that other stuff. So it's difficult to change those resources. In terms of self-regulation, this requires kind of sustained motivation and effort. And for CF, that means focusing on having CF and why they would want to do their treatment. And we know, and the whole literature in this area, people don't want to focus on having CF. These are young people. They want to focus on being well and having great lives. They do not want to keep focusing on the fact that they need to take treatment for their condition, and many of them avoid that. There's also something called ego depletion, which I'll talk about in a moment, that may make that more difficult potentially. And we know that it's disrupted by other conflicting goals. So back to the kitten, I'm not going to show it to you again because we'll get distracted. But all those kind of things that are going on, stressful life events, other desires, impulses. So it's difficult to maintain over time. And indeed, these are two people from our pilot feasibility study, just to illustrate that. So these kind of blobs are where we've intervened, and this is where they've kind of looked at their data. So this person, they start off with kind of 5% adherence, and then there's a bit of, they know they're being monitored, so that probably encourages them to start adhering before we've intervened. We've intervened, and then they're doing really well for a bit. They're doing fantastic amounts of their treatment, drops off a bit. I think we intervene again here, it comes up a bit, and then by the end of this is 5 months, they're kind of back to where they started. So there was some kind of effort, I can do this for a bit, self-regulation, but it wasn't sustained. This person is even more interesting. So this person said that they would be in the trial and they'd adhere for the trial, and that's exactly what they did. So they'd gone up to here before we'd even seen them. There was a bit of a delay, and they maintained their adherence at 85%. Until they thought the trial was over, which was slightly before it was, and then they stopped. So completely self-regulation. They decided they were going to do it, they did it, they stopped doing it. Clearly this isn't going to help maintenance over time, generally though. Ego depletion. So there is some conflicting evidence around ego depletion, but I'd explain what it is. The idea is that people have a kind of limited pool of mental resources, and they get used up. So kind of the self-control and willpower you need to kind of keep going along something, you've only got a certain amount of that, and you can't use, it runs out. So in terms of the effort of self-regulating adherence, it may be that when other things come along, like stressful periods, or perhaps another treatment is added in, which happens quite often, people often have diabetes as a comorbidity, it may be that it just kind of pushes self-regulation over the edge. And I think people kind of understand this. So if you think about studying for exams, you're using all your effort to spend time on doing that, it's not a good time to give up chocolate. Okay. So in terms of habit interventions for adherence, there is some evidence that this is a good idea. So Connor and Rupert did a systematic review of a meta-analysis of 771 medication adherence interventions. And they found that those that were based on habit-based kind of interventions were more effective than those that were based on kind of knowledge or beliefs. So not changing the kind of necessities and concerns stuff were much less effective than those that are based on habit. So in terms of habit formation, this is Gardner and Lally's model. The idea, and I've kind of related this to adherence, is first of all, you need to decide to act. So you need to have an intention to want to adhere, as various people have talked about earlier today. Then you will initiate that action, so you'll be self-regulating and you'll be trying to adhere. And then with repetitions of that behaviour, developing cue behaviour associations that result in habit formation. So that's what we're kind of aiming for. I do have a whole other presentation on how we developed this intervention that I'm just completely pasting over. So I'm just telling you what we did. So this is the aim of the CF Health Hub intervention. We're aiming to get people to habits, but we're going through this route here. So firstly, there are a whole series of behaviour change techniques to encourage people to want to adhere for those that don't. So the first thing we've got is we can feed back objective adherence data to people so they know what their adherence is. And people, before that kind of, certainly some of them and the lower adherers tend to overestimate. So that kind of can help with sort of self-monitoring and self-regulation. We try to kind of raise reflective motivation, the kind of motivation we've been talking about this morning, by addressing necessity and concern beliefs. We have animation videos about how treatment works. We also elicit people's personal motivations for wanting to adhere. For example, wanting to attend their sister's wedding in the summer and not being in hospital. So things like that, so people are listing their own motivations. And we try to increase confidence by focusing on successes that they've had, rather than where they've not done so well. By setting achievable goals, so if people are doing no treatment at the moment, we don't say you've got to do 5 nebulizers tomorrow. We kind of set smaller goals that they can work towards. And we also have some role models of people similar to them, videos from them, talking about how they've managed to increase their adherence. We then get people to make action plans, identifying a cue to treatment and making a plan for exactly when, where and how they're going to do their treatment, to enable that consistent repetition. And we also support them to make backup plans to boost motivation when they're tempted to miss their treatment, to create alternative plans for unusual situations. So going on holiday, weekends are also unusual situations. They're quite usual, but the week is different to the weekend for many people. And to solve some of those capability and opportunity barriers. So we're hoping to persuade people to kind of have that effortful self-regulation, and then with repetition that they will form habits, which should be less effortful. So that complex intervention, we have a number of outcomes, one of which is adherence, but we also have some clinical outcomes around kind of IV days and lung function. And that's been tested across 19 sites in the UK. We've trained 27 interventionists to deliver that intervention, and we've recruited over 600 patients. It was delivered over 12 months and it ended in June, and that's me being quite scared about the results coming out in a couple of weeks' time. For the team anyway. The results in terms of the public will be out at some point. We also did process evaluations so we understand what's kind of happened in that intervention, and we did things like fidelity assessments, and we very, very closely monitored these interventionists, just referring to a point we made earlier. So how do we, just to kind of go back to how we're helping people to make a habit in that intervention, we're asking people to identify a cue, so a consistent environmental stimulus, and then making an implementation intention type plan. So they're saying, if I come across, or when I come across that cue, then I'm going to take my nebulizer treatment. As Armitage called it, a kind of instant habit. And they're making that commitment, they're creating the cue, they're repeating that behaviour. So after I've had my breakfast, then I'll do my nebulizer treatment. Or when I have my breakfast, then I'll do my nebulizer treatment. We have found, kind of from doing this, that supporting people to make that kind of very specific cue can be somewhat challenging. And I think one of the key things is that the cue must absolutely come before the behaviour. And when we've talked to people, they can identify times or things that they're doing in their day that they could link to their treatment, but it doesn't necessarily come before. So an example is, I'd like to do my treatment when I walk the dog. Okay, so you can't do the treatment when you're walking the dog, and if your cue is walking the dog, then actually it would have to be after you've walked the dog, kind of not before. So you need to make sure that the cue happens just before you want to do the treatment. So it might be that putting your shoes on, your walking shoes on, would be the cue. So we've had to work with people to kind of get them to identify appropriate cues. The cue needs to be encountered regularly, and we've kind of adjusted those kind of plans as we've gone on. Time is not a particularly good cue unless you've got an alarm going off on your phone, because we don't spend all our time looking at a clock. So it's easy to miss 8 o'clock. So it's better to have a cue that is a thing that happens. So a TV programme you always watch at 8 o'clock would be a better cue than the time. And then, because we're at the beginning it's goal directed, we probably need to plan for these times of low motivation or barriers to behaviour. And the example I always give is I try and, it's not habit, I try and go for a run on a Saturday morning, so I repeat that fairly frequently, but I hate running in the rain. So I kind of need a plan that is what I do if it's raining, because it's not, I can't get it to do that. So we probably need those kinds of things as well. The other issue in terms of the kind of theory of habit formation is, when do we know that habits are formed? So I've shown this graph before and people have gone, well, they're just doing it more often. It's more frequent, and it is. So it's more frequent, so it feels kind of more automatic, feels easier because it's more frequent. And it is quite difficult to separate frequency from that automaticity in terms of the definition of habit. In terms of the kind of measures of habit, we have a couple of self-report measures. So the first is called the Self-Report Habit Index. It has 12 items and it measures perceptions of repetition of behaviour, automaticity. So, I use my nebulizer without thinking about it, or self-identification with action. There's been some criticisms of that, in that the repetition and the self-identification are not specifically habit. They're kind of the outcomes of habit, if you like, the symptoms of habit. So there's also the self-reported behavioural automaticity index. It's all very easy to say, isn't it? Which is the automaticity items from here. These aren't brilliant. Can people self-report automaticity? It's debatable. Okay, you're reflecting on whether something you did was automatic or not. In repeated behaviours like our adherence, it's actually quite problematic. We know from our data that quite a lot of people have a really strong habit for their morning treatment and not a good habit for their evening treatment. So if you ask those kind of questions, the response is, which ones are they answering about, is challenging. And it's not really assessing that. Is it a cue response thing that's happening here? So there are some other ways to try and measure this. There's something called frequency and context measures. So you look at how often behaviour occurs in the presence of the cue. They're not necessarily habitual, of course. So you might do some behaviours in a consistent situation that aren't habitual. So doctors in a consultation with a patient might do a number of things, but they're doing them deliberately. They're not doing them kind of habitually. And it also requires people to be aware of what their cue is. So it's fine, kind of, we've identified for our study, we've got people to make those plans, those cue responses. But if you think about the habits that you do, it would probably be quite difficult for you to identify exactly what the cue is for those behaviours. And then there are lab-based measures of habit. So here again, you need to identify the cues. And there are methods, for example, where you present pictorial representation of cues and behaviours, and you look at the reaction time. So do you respond faster to cue and behaviour versus kind of a control cue and a control behaviour, for example? So there are difficulties in measuring whether something is truly habit. So you can worry about that if you want to, or you can say, actually, I'm just worried in behavioural maintenance and I don't really care. But I just thought... So that's a kind of debate whether that's important in terms of behaviour change. What we're doing after the randomised control trial is we have created something called a data observatory. So all of the sites that were in our pilot trial and the sites that are in our randomised control trial are continuing to use those nebulizers that time record when treatment is taken. And that's continuing to be used in kind of clinical care. So there's a number of aims for that. Firstly, the aim is to make adherence data part of all consultations. It's difficult to know what's going on with a patient unless you know whether they've been adhering or not. You don't know if they've been getting worse because their treatment's not working, or of course they've not been taking it. To use the kind of intervention, and we will refine it post-RCT, to support patients with adherence, but also to study the data to try and understand habit formation. So we think that, and there's evidence that it's easier for some people to form habits than others. Things around people who have routines probably makes it easier for some people. How do we know when a habit's been formed? So there are some clever colleagues of mine that are going to look at whether machine learning can identify that. I don't know how that works either. How much support do people need to create a habit, which is really important? How long do we need to support people before we can take a step back and be assured that their treatments are habitual? Kind of understanding this habit-based, self-regulation-based maintenance, and also when habits break down. So we know, for example, that changes in context should impact on habits, and many of our young people are of the age where they go off to university, all their cues disappear, pretty much. So what happens then? How long does it take to build up new habits? So kind of summary and sort of take-home messages. I think in terms of habit positives, there's growing evidence of their role in behaviour change and particularly behavioural maintenance. So the kind of intention behaviour gap that Mark was talking about earlier, using this kind of planning, if-then planning, and using that to create habits may be a way to do that. And they should require less cognitive effort once you've created a habit, which is obviously beneficial to the people that make them. You don't want things to feel effortful, you want them to feel easy. But there are challenges. It's not clear if everyone can create a habit. So one of the key papers that looked at habit formation only recruited people who wanted to do a behaviour, and still only about half of them made a habit. It's not clear how long they take to develop, and it's difficult to establish true habit from routines. The measurement ideally requires the identification of cues, and it may not be suitable for all behaviours, but some kind of a potential area of interest, hopefully. So, thank you.
Right, brilliant stuff. So our last formal talk of the day before a discussion is from Fuschia Sirois from the University of Sheffield. And we're going to talk about self-compassion as a motivator for health behaviours. Thanks,
Yes.
Fuschia.
Okay, thanks, Ian. Okay, so yes, so a slightly different turn of topics here. We've been hearing a lot about intentions and habits and a lot of the more cognitive elements of health behaviour change. So my talk's going to focus on something that Mark touched on, which is that we need a little bit more to consider some of the effective components of health behaviour change. And so I'm going to be addressing that, presenting some theory and evidence on why self-compassion might be something to consider for motivating health behaviours. Now, how many of you here have heard of the term self-compassion? Ooh, quite a few. That's good. All right. Okay. So hopefully I don't have to do too much explaining as to what it is. All right. So we've heard a bit about the intention-behaviour gap, this idea that we have intentions and intention strength, and that's a strong predictor of behaviour. But at the same time, there's a lot that's not explained in terms of getting people to move those intentions 100% over to actually taking action. In addition, the action is usually the initial action, so it's the initiation of a behaviour change, but not necessarily the maintenance. And I was really pleased to hear Ian say at the very beginning of the day that, again, this idea that the motivators that are involved in initiating action are not the same necessarily as those that focus on the maintenance of that action. And so most of the health behaviour change theories and tools and techniques are targeted at sort of bridging this gap between intentions and behaviour. If we think about intentions, though, it's fairly straight, fairly direct route to that initial action, right? And we can use tools, different techniques, and use different theories and apply them to get people to start on that action. And initiate sort of the first step towards making important health behaviour changes. And it would be really tempting to think that from that point onwards, the upward trajectory towards sustained health behaviour change is this wonderful, ideal straight line. But in essence, and I think in reality, what we do see is that the difference in terms of the trajectory is one that's not quite as straightforward. People don't just set off and then 100% are successful making those health behavior changes, improving their exercise and activity levels or changing their diets. There's a number of peaks and troughs within that path towards successful behavior change and sustained behavior change. And what I'm particularly interested in is what happens when people hit those troughs in the pathway up towards sustained health behavior change. It's at these points when people have goal lapses. So they may have set a goal towards going to the gym 3 times a week, for example, and they miss a week, and they feel bad about it. Okay, and these negative responses then tend to be the default response for most people, sort of a critical response. And for certain individuals, that default, very negative, self-critical response can then actually engender not continuing on with the health behavior that they've intended and set out that they want to engage in, but rather can get them procrastinating on it or abandoning the goal altogether. So I guess you might want to talk about not just the intention behavior gap, but the behavior initiation and maintenance gap. So what do we need to get people through those ups and downs where they've initiated a behavior change and it hasn't yet become something that's part of their regular lifestyle or routine? And in my talk today, I'm going to propose that self-compassion is one possible way of helping people to bridge that gap between the initial taking the first steps towards making health behavior change and maintaining that health behavior change over time. And there'll be a number of reasons I'll propose for why that might be, and I'll sort of get on with those in just a moment. Okay. So first of all, for those of you who don't know what self-compassion is, I won't spend too much time on this. It seems like a majority of you knew what it is. It is a concept that has been primarily, there's a couple of different theorists, but Kristin Neff tends to be the most cited theorist in this area. She's a pioneer in the work of self-compassion. She's written popular books on it, etc. But basically, her conceptualization of self-compassion derives from Buddhist psychology. And it's this idea that self-compassion is not just we treat other people with compassion, but it's showing that same compassion towards yourself in instances when you're dealing with your own failures and flaws. So formal definition here is it's taking a kind and understanding stance towards oneself in instances of pain or failure, rather than being harshly self-critical. So that's sort of the very global definition. I'm going to break it down into some of the components that she says are essential for self-compassion momentarily. But the other thing to note here too is that self-compassion is not just a state. Okay, it can also be an enduring quality, almost a trait-like quality, so that you can cultivate a self-compassionate mindset. And much of the research that's been done looking at self-compassion in the context of health has initially looked at anyways this sort of self-compassionate mindset and how it related to health-related outcomes. So Neff suggests that there's sort of 6 different components of self-compassion. They're bipolar components, so I'm going to show you the positive components first. So the first is self-kindness. And these are items actually from the scale that we use to measure self-compassion. It's saying I'm tolerant of my own flaws and inadequacies. Then there's this notion of common humanity, which is basically trying to see any struggles or failures or flaws that you have as just part of the human condition. Nobody's perfect. Everybody makes mistakes. Everybody fails at one particular point. And sort of taking a bit of comfort in that knowledge rather than sort of seeing yourself as being quite different. Everybody else is succeeding and I'm not, which can actually just aggravate some of the feelings that arise when people are dealing with lapses in their goals. And then the last component is mindfulness. Now this is some similarity to what most of us hear about in terms of mindfulness meditation, etc. But in Neff's model, mindfulness refers to sort of keeping a balanced perspective on one's emotions, identifying that you're, noticing that you're feeling bad about something, and also that you're feeling good, but not getting sort of swept away with those negative emotions and over-identified, right? The idea is that people become so wrapped up in the negative emotions, they lose perspective on what they're doing. So the negative poles of these 3 dimensions then are self-criticism, which is sort of self-explanatory there, so being disapproving and judgmental when you make mistakes, feeling isolated in your suffering rather than realizing that other people are also suffering. Just because they have a smile on their face doesn't mean that they're going through life without, problem-free. And then, as I was just alluding to, this idea of over-identification, not seeing yourself as those negative emotions, being able to separate yourself from those negative emotions, and then take a more balanced perspective. I also wanted to lay out this right out front because sometimes it comes up when I do talks on self-compassion. Self-compassion is not self-indulgence. Some people think it is, and that actually is a bit of an issue, especially when you try to convince people that being self-compassionate when they're dealing with these sorts of lapses might be something that's beneficial for them. But I'll get more into this idea of some misperceptions that people might have about self-compassion a little bit later on in the talk. So some of the early research suggesting that self-compassion might be beneficial for motivation was first done back in around 2012. There's a series of experimental studies. In this paper, there was actually 4 studies. I've just got 3 of them up here. And basically what they did is in a lab type setting is they had people either recall failures or recall something about themselves that they weren't happy about, maybe a personal flaw, and also put them in a situation where they had to do a really, really difficult task, right? So they had to a vocabulary word test that was really difficult and almost unsolvable, and then basically said, okay, we're going to give it to you again and see, you know, how well you persist and how motivated you are. And each of these different types of failure type scenarios, they found that people who had been prompted to think about their failure in a self-compassionate manner showed higher levels of motivation and persistence with their tasks. So this is some of the early research that suggested that self-compassion might be beneficial for motivation. It was from this point onwards then, in recent years, there's been more of a shift to thinking about self-compassion and its benefits for motivating health behaviors in particular. So, like I said, most of the research and the evidence-based in self-compassion and health is relatively new. There was a systematic review of only 7 intervention studies, so there's not much literature out there right now. But in that particular systematic review, the authors concluded that self-compassion interventions were just as effective as other behavior change techniques at improving self-regulation of health behaviors. That's quite, it's quite a statement to make, given that sort of the long history that many of these other behavior change techniques associated with theory of planned behavior and other theories, and they're quite well established, but it turns out that those that use self-compassion seem to be just as effective. And so it's research like this and that has sort of got people thinking about self-compassion in the context of health and health behaviors. What I'm going to be showing you over the next few slides is not just that it is related to health behaviors, but why it might be related to health behaviors. And I'm going to propose 2 routes here. One of them is the emotion regulation route, so that's an affective component. That self-compassion has to do with responding to failure in a healthy and adaptive manner that allows people to get on with monitoring and regulating their health behaviors. And the second is a bit more abstract. It's more of a temporal pathway. As we know that sort of thinking about the future is important for any types of goals, and especially health behavior goals. And this sort of pathway suggests that people who are self-compassionate then might have a better connection to their future self. And having that connection to the future self enables them to maybe overcome some of the difficulties that many people face when they're trying to regulate their goals in the context of temptations and other barriers. Okay, so Maddie's already laid out a bit about self-regulation, so I put my little thing up there in case someone hadn't been covered. But again, this capacity to control one's thoughts, feelings, behaviors to achieve long-term goals. And if we can think about self-regulation rather as having 3 main components. Goal setting, we heard a little bit about that this morning, this idea you have to set goals and the notion that these goals should be autonomously set rather than prescribed. Then once you have a goal set, you have to monitor your progress towards that goal to make sure that you are in fact doing the right things to achieve that goal. And then lastly, that you need to be able to shield your goals from temptations and impulses, as well as be able to align your goals, your behavior rather, with the goals that you have in mind over the long term. So self-compassion as a sort of healthy adaptive response to failures might be particularly important in the goal monitoring process, and as well as within the goal shielding and alignment process too. With respect to the monitoring, emotion regulation can be key. Because if you think about it, when you're monitoring a goal, what you're constantly doing is you're saying, that's where I want to be, and this is where I am. And initially, when you're working towards a goal, there's going to be quite a bit of a gap, okay? And that discrepancy or gap doesn't feel very pleasant, okay? It creates a sense of aversiveness. It can raise negative feelings. It can lead into self-doubt for some individuals. And sort of being able to manage those negative emotions during the monitoring process can be important. As well, negative emotions themselves can be disruptive to goal monitoring, as I'll explain a little bit more shortly. With respect to goal shielding and alignment, if you have your future self in mind, when you're engaging in making decisions about whether to give in to an impulse or a temptation, or think about your future goal, the more that you're able to call up and feel connected to that future self, the easier it will be to make that goal alignment. So just briefly here, a little bit on why the negative emotions might disrupt self-regulation. There's a couple of different theoretical perspectives on this. One is that, sort of more immediately, is it triggers short-term mood regulation. So you may have this long-term goal, but when you're feeling bad about things, and we don't like to be in an aversive state, right? We want to do whatever we can to reduce whatever that source of the aversive mood or negative mood is. And so for many individuals, if you're feeling bad about a particular goal, you're worried about, whether you're going to be able to follow through with the health behavior changes that you want to make, or you're struggling with getting into a new routine, your focus shifts to immediately regulating that mood and wanting to feel better. Okay, and you see this with food, of course, a lot too. That was sort of spoken about a bit earlier. So you might take actions that reduce that negative mood and make you feel better in the short run, rather than are focused on regulating your immediate behavior. And that way it can actually interfere with self-monitoring. And we see this a lot in phenomena such as procrastination and other forms of behavioral disengagement, which are really just sort of an avoidance of anything that causes negative mood. And also, when you're in a negative mood, it narrows your temporal focus. So your immediate concerns and trying to manage that negative mood takes precedence over your long-term goals. Another way of saying that, sort of a little bit more of a temporal language, is it foreshortens the action contingency temporal horizon, and it can lead to poor intertemporal choices. And what I mean by that is that when your focus is to feel better now, you're only thinking about how your actions have an effect on the immediate. Okay, so your temporal horizon is this action will have this effect within this short period of time. When we're working towards long-term health behavior goals, such as increasing physical activity or changing our diet, the temporal horizon is quite distant. Okay, and we need to be able to have that distance there to overlook any of sort of immediate pressures that we might be experiencing. But when we're feeling negative about things, where we're feeling anxiety or stress, and this might have partly to do with sort of systems within the brain, the amygdala being activated, sort of threat centers, we're focused narrowly on whatever that threat is, we can't think about the future as easily. So one model I proposed and tested that sort of brings together these ideas about affect and sort of temporal focus, and so it basically puts them under an umbrella of being self-regulation resources. So the extent that you have low levels of negative affect, high levels of positive affect, and a higher future orientation, these are resources that people can draw upon when they're engaging in trying to make health behavior changes. And self-compassion would certainly fit within this sort of model here, and this is some of the research I'll be showing, so provide some evidence to support this. Okay, and you'll notice the cute name of the model there, the TASER model. I like acronyms. I couldn't think of anything better than that, but it's a temporal effective self-regulation resource model, and it's just basically, again, highlighting the role of effective responses and temporal orientation in engaging in health-promoting behaviors. Okay, so how do people respond to lapses while pursuing health goals? So we had that sort of zigzaggy diagram earlier. That default response for many people is self-criticism. Self-criticism leads to negative mood leads to poor self-regulation, procrastination, abandoning goals. So this is sort of the automatic response and what it can lead to for many people. If you introduce self-compassion, which is known to decrease levels of negative mood and increase positive mood, that might improve self-regulation, motivation, and therefore increase health behavior. So that's kind of the model that's sort of working on looking at sort of the chain and sort of the potential causal pathways linking self-compassion to health behavior through mood. And that was sort of on the underlying, model for understanding for this particular paper that looked at self-compassion and health-promoting behaviors. And so this is research we did a few years ago now. At the time, there was no published research linking self-compassion to health behaviors. So what we did is we gathered together 15 independent samples. These included students, adults from the community as well as people from chronic illness populations. And then basically the idea was to look at the association between self-compassion and these health-promoting behaviors, and also to understand the role of affect within those relationships. Just so you're wondering, how was health behaviors measured? So this is a wellness behavior inventory that I've used for a number of years. And people basically report over the last 2 weeks the frequency of engaging in a number of different behaviors. There's some reverse score behaviors. It's based on a theoretical model that suggests there's replicable dimensions of health behaviors, and so these are all health promoting. You'll notice there's no smoking or alcohol because that actually forms a different dimension of health behaviors. But there's exercise, caffeinated beverages, getting good sleep. So it's kind of a nice overall index of health behaviors. If you are interested in this, it is available for download off of my lab website, so I make it freely available to those that might want to use it in your research. And it gives you a mean score that tells you how frequently do people engage in these health behaviors. So overall, across the 15 samples, and I found that there was sort of a small to medium association between self-compassion and the practice of frequent health behaviors. Okay, this is great. This sort of fits with what the theory that I'd laid out suggests. But more importantly, getting back to that why, we looked at the mediating role of positive and negative affect. So basically looking at whether that could explain the relationship, or the extent to which it could explain the relationship. And yes, I have a kitten on my slide too. What we did find was that we looked at the analysis of the average effects across the studies that had measures of positive and negative affect, and found that higher levels of positive affect and lower levels of negative affect, as well as when the two were combined, explained why self-compassionate people practice more frequent health-promoting behaviors. So affect does seem to be key here in linking self-compassion to sort of motivation for health behaviors. We've also looked at self-compassion in relation to medical adherence and done this across a number of different samples. So we've had 2 fibromyalgia samples, 1 chronic fatigue sample, a sample of American war veterans, a sample of people with cancer, and a sample of people who are cancer survivors. In each of these different samples, basically we found again that self-compassion was positively associated and significantly associated with better medical adherence. Now I want to note here that medical adherence was measured by a very general measure. It was a medical outcomes studies general adherence measure. So it's not just medication adherence. This is anything from engaging in disease management behaviors to as well including exercise and proper diet that may have been prescribed by their physicians. We also wanted to again look at the why for these associations, and in this respect, rather than looking at negative affect, we looked at stress as a negative affective state. Okay, that might also explain why self-compassionate people were better adhering to the recommendations from their physicians. And the idea here is they have lower levels of stress, and stress as a negative affective state might be disruptive for regulating this particular health behavior. And again, across all 6 of the samples, found again it was about 0.28 association, average association with adherence, and we meta-analyzed these effects. And importantly, we did find some evidence. It wasn't a huge amount of variance that was explained in medical adherence, but 11% or almost 12% of the variance in medical adherence was explained by lower levels of stress associated with self-compassion. And one last behavior, something some of you may know something about, perhaps, something called bedtime procrastination. It's actually a really important health-related behavior. It has to do with sleep insufficiency. This is a phenomena that was first noted in by some Dutch researchers. And they've noted that 74% of people actually engage in bedtime procrastination. So this is unnecessarily going to bed, despite knowing you'll be worse off for doing so. This can be staying up at night watching too many cute kitten videos, or binging on Netflix, or Amazon Prime, or just reading, into the wee hours. So it's engaging in pleasant activities, and we sort of hypothesize that one of the drivers behind sort of this particular unhealthy sleep-related behavior was poor mood regulation. In other words, that people were using it to regulate their mood in an unhealthy manner because they were troubled by something that happened in the day. They were worried about what was going to happen the next day. So rather than having those thoughts and not being able to manage those thoughts internally, they engaged in these other activities that would put a smile on their face, at least temporarily, but also kept them up too late. We looked at self-compassion with respect to emotion regulation, which is this idea of being able to down-regulate negative emotions and up-regulate positive emotions. The results were replicated across 2 studies. I'm just showing you the one here, which is from the larger sample of over 600 people. What we looked at and found was that self-compassion was positively related to this cognitive reappraisal. So it's, again, looking at your difficulties and seeing them as being part of the human condition. Right? Or not being self-critical and being a bit more self-understanding when you are looking at your own flaws. Interestingly, though, the main explanatory route was not through positive affect, but it was through lower levels of negative affect. So self-compassion allowed people to cognitively reappraise any difficulties that they may have been experiencing that were contributing to bedtime procrastination, and this happened through lowering their levels of negative emotions. Okay, so if we think about intertemporal choices, the present self is always trying to choose between something that might be healthy versus unhealthy. And in those instances, you might be thinking very temptingly to think about the future self. Like, okay, so right now, yes, that big, unhealthy piece of cake or that juicy burgers would be really, really good right now. It would make me feel good. And as a sort of a rationale for maybe giving into that temptation, you might think, it's okay if I give in now because future me is going to make all the perfect health choices. Future me is going to go to the gym. Future me is going to exercise properly. Future me is going to turn down those unhealthy foods and eat the healthy foods. And so very often people find themselves in this particular sort of temporal dilemma, and they may opt to make the not so healthy intertemporal choice of giving in to feel good at that particular moment. The problem is that when this happens recurrently over time, so if it's not just a one-off, it's something that people repeatedly do, sort of assigning responsibility of their health behavior change to their future self, it can start making the future self somebody that maybe isn't quite realistic, because future you is going to have all the willpower, not be tired, be able to sort of stand up and sort of follow through on those goals that you want to follow through on. And in that way, your future self becomes almost like a superhero, right? It's this incredible person you're going to be next week or next month when you're going to be able to follow through on all those goals and those health behavior changes you want to. You're going to run the marathon, you're going to be going to the gym regularly, but it's not right now because, you're feeling a little bit tired, right? The problem is when you make the future self sort of the standard that's so unrealistic, it creates a psychological distance. Right? That future self no longer feels like you. It's somebody that you can't relate to because you're not doing any of those things right now, right? And that distance then causes people then to disconnect from that future self and not feel particularly connected. What it also does when people regularly assign responsibility of their health behavior changes to their future self rather than their present self is they make their future self their beast of burden. Okay? So now the future self is having to deal with all these leftover promises, all these things that were left undone. That's not being particularly kind to one's future self. So if we flip this around to a self-compassionate perspective then, we can think about people who are self-compassionate, that they extend that self-compassion not just to the present self, but also to the future self. They wouldn't necessarily make choices that are going to harm themselves in the future, because it's still the self, it's just another temporal self, right? And so one way of assessing that is this measure that Hal Hirschfield came up with called future self continuity. It's a very straightforward measure here. Basically, you see a couple of Venn-like circles, and people indicate the extent to which they feel their current self is connected or overlapped with their future self. And this is usually on a score of 1 to 7, so higher ratings mean greater future self-continuity. So this is, I don't think I got the message about new data, but I happen to have some new data in here. So
I
there
didn't
you
know
go.
I'd said it.
Oh, there you go. I was hearing that and going,
Perfect.
I'm presenting studies that are already published, but this is new data. Okay. Okay. So we've looked at self-compassion and future self-continuity, again across 15 samples over almost 4,500 people, and in every single sample, and I don't know if the laser is working here. No, it's not. Oh, it is a little bit. Every single sample in the first row there, you can see that being self-compassionate is associated with higher future self-continuity. So people who are self-compassionate feel more connected to their future self. Now we know that future orientation is an important predictor of health behaviors, right? Because you have to have goals in the future. This is what I'm going to do later. You have to be able to see yourself in the future and be able to think in a more future-oriented manner to be able to even set that intention and that goal in the first place, and then to sustain your efforts towards achieving that goal. Okay, so this is association, right? It's meta-analyzed, big data. It's good, right? But it's an association. And it's a trait level. Okay, so next step then was to say, well, what happens if we experimentally manipulate self-compassion? What if we get people to respond self-compassionately in the moment? What does that do to the feeling of connection to themselves? So in this one particular study, it was a scenario study. There was people who, the sample, were working on a health behavior change, so it was all very salient for them. It just wasn't just people not doing anything. They all had to say what their behavior change they're working on. Most of them were working on diet and exercise changes. And there was 2 conditions. In the self-compassion condition, they read a self-compassionate response to a health behavior failure. So both were presented with, or asked to sort of come up with a time when they'd recently had a failure making their health behavior change. And those self-compassion condition wrote a self-compassionate response. Those in the control condition just asked to write sort of things about the day, the weather, you know, what they were wearing the day that they had that failure, etc. What we found, and I don't have the control condition data here just for simplicity, is that just getting people to write in a self-compassionate manner really changes their levels of state self-compassion quite dramatically. So it's, again, this fits with the research. We know that self-compassion is something that can be cultivated even in the moment. Although this doesn't look like a huge change, it is still a significant change. And simultaneously with increases in self-compassion, they also felt closer to their future self. Okay, and there was nothing about talking about the future in there that would have triggered that. It was mostly about thinking back. So in fact, they were thinking back to the past, and yet this made them feel closer to their future self. And these changes were significantly different from the changes that we're seeing in the control group. Okay, so as I'm saying, some of this self-compassion can be prompted in the moment. There's a number of different interventions out there. In an experimental manipulation, it's often just getting people to write about their experiences or their perceived failures, sort of tapping into that self-kindness, common humanity, and mindfulness. And that's often enough to change significantly their levels of self-compassion. And these are some other types of instructions that have been used in the literature, sort of give you a flavor for how we sort of cultivate self-compassionate responding to perceived failures. There's also a number of formal and informal ways of cultivating self-compassion. So some of these are happening in sort of more of a clinical setting, mindfulness-based cognitive behavior therapy, mindfulness-based stress reduction, there's compassionate mind training. And then Kristen Neff has a website with a number of self-help exercises that anyone can go to and download. And these are actually quite straightforward. So how would you treat a friend? So you get somebody to think about something that might have happened, maybe a mistake that they made or a failure they experienced with as they were working towards trying to exercise more or change their diet. And you would basically, rather than asking them how they would respond to themselves, which often is the default, is to be very self-critical, so you put it in the place of friends. So imagine your friend is trying to become more physically active and eat healthier, and she's just had a bad week and she didn't go to the gym and she indulged in pizza and really is feeling bad now about the fact that she sort of got off track with their health behavior changes, what would you tell her? What would you say to her or him? And you get them to write that down, and then you flip it around to basically, so why, are these the sorts of things you're saying to yourself? And if they're not saying them to themselves, then you kind of, when people see that stark difference when how we respond to other people with compassion versus themselves, at first it's sort of bringing awareness to when people may not be responding self-compassionately. That's sort of the first step. Okay, and then there's other exercise too that can be done on a daily basis. Okay, so now I may have convinced some of you that self-compassion is something that's important to consider in the context of health behavior change. It might be something you're thinking, okay, this is great, I can incorporate it into some of the programs we're looking at, sort of brings in that affective dimension. This is all really good, right? Okay. I think it's really good, but it's not as straightforward as we would hope it would be. There are some challenges. And the challenges are that there are barriers to being self-compassionate. So there's some emerging research now starting to come out. Some of this is qualitative. There's at least only one quantitative study. The other studies are qualitative. And basically suggesting for certain individuals, those high in self-criticism, so perfectionists, for example, find being self-compassionate extremely difficult. Qualitative studies have found that self-compassion is not seen as not fitting with social norms. I like this quote here. The idea of being kind to yourself, I can see it as a good idea, but on the other hand, somehow I feel like it's not British. So the norms about responding to yourself and thinking about yourself rather than, thinking about others, which is what most people are more comfortable with doing, can be a barrier. Lastly, if somebody is low in self-compassion and may be struggling, and they may be one of those individuals who's a candidate for abandoning their goals when they hit one of those inevitable lapses in their health behavior change efforts, those individuals tend to have very negative views of people who are self-compassionate. So in one particular study, they separated people into those who were high in self-compassion and those who were low in self-compassion. And they put a number of different personality traits in front of them. And they got them to rate. Think about, someone who is self-compassionate. How would you rate them on these traits? So the self-compassionate people rated a number of very healthy traits. But the people who scored very low in self-compassion, they saw people who were self-compassionate as being low in motivation, which is counter to the research that I've shown you today, self-indulgent, lazy, having poor performance, selfish, less conscientious, and less competent. So if people hold those views about what self-compassion is, and these are erroneous views, and again, not necessarily understanding what self-compassion means, that can be a real barrier towards implementing self-compassion in any type of behavior change program. But thankfully, we just received a nice ESRC grant, starting next week actually, for the next 3 years, and with my colleague Tom Webb at Sheffield and our new postdoctoral research associate, Dr. Marius Biscus, we're going to be looking into finding ways and using behavior change techniques, in fact, to find ways to help people respond in a more self-compassionate manner to their goal lapses so they can help them reach their goals. Okay. And that's all I've got for you, and thanks for your attention.